Okay. Hi everyone. So thank you for letting me like pre-record this. I figured this would be a good one to pre-record because everything's kind of straightforward. And as per usual, you can watch this in 1.5 speed. So we're doing GI embryo and path today. Here's my little reminder. It's just like in my slides now. I have absolutely no idea what's on your exams, and if I say something's important, it's more so like that's what I think is important, like to know and to kind of gather from, this content. Okay, but it's like I said, PBL exams can ask whatever they want. So it's just like a little reminder. So what I'm gonna do today is I really want to go through the portosystemic anastomoses. I know that's not really embryo, but it is path, but it's anatomy path. So I did want to cover that. I do want to cover that. Um, and then go through GI embryo and the related pathology. And then I put hernias in here because it's not on your syllabus, but hernias is one of those things that can come up in GI block. I personally consider it more of like a repro thing, but I do think it's like one of those things that can be tested in GI. So again, it's another one that I thought would be good to put in like a pre-recorded lecture because you guys can skip it if you're like, yeah, I'm not gonna do it. Like I don't care, So it's like it's up to you. Like it's there for you if you want it. But at least there's two hernias I think you absolutely should know for this exam. But then like the inguinal hernias, it's like a hit or miss. Like, it might come up on this exam. If not this exam, definitely repro. So at least you'll have it for repro. Okay, and then questions. Okay, so the reason I wanted to actually physically talk out portosystemic anastomoses is because I was facilitating last year for the now second years, and someone did an LI on portosystemic anastomoses, and all good intentions, had very good intentions. It's just the kid explained it completely wrong. Like he kind of explained them as this is like a physiologic thing, and it's like, oh, look how cool the body is. It just shunts blood around everywhere. And I'm like, no, 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 no. Usually I'm not like trying to jump in every time, but it's like this is path. This is a very pathological thing that can happen, usually from like cirrhosis of the liver. Okay, so these are not, because whenever we think of anastomoses, we think of like these connections that are physiologic. They help get around pathologies. These are pathological. Okay, so really wanted to emphasize that just because of that LI from last year. So these are a must know. You got the capital letters and the highlight. I had a few questions on my boards about portosystemic anastomoses, especially for your exam. It's just a high yield kind of pathology state. And like I said again, this is pathology. This is not normal. Basically, what happens, it kind of tells you in the name, portosystemic. It's like the portal system and then the systemic system, which is like from, the heart, the vena cava. They all kind of connect to each other, which is normal. But if you have something like portal hypertension, whereas like the portal system backs up, again, cirrhosis of the liver, something like that, it can go from the portal system to the systemic system. And then there's these three like main portosystemic anastomoses. Oh yeah, I have on here a question for you guys if I were to do this live. So this is like where the patient's portal system blood gets backed up. This is usually due to cirrhosis, but what cardio reason would cause this? Because you guys just had cardio, right-sided heart failure. So if you have right-sided heart failure, that can go back to the liver, and then it can cause liver failure, and then you can get portal hypertension from that. Typically, when the heart causes, like heart failure causes liver failure, they call this nutmeg liver. And it's just from the appearance of the liver. It looks, I guess, like nutmeg. I never really thought about what nutmeg looks like, but it just kind of gets all blotchy looking and like it gets discolored and it's like light tan colored. It's kind of weird. But because of this portal system, like this, the fact that these systems are connected, you can actually see systemic manifestations of this portal problem. So that's kind of why these are super high yields. And there's three main ones, and help everyone remembers them is gut, butt, and kaput. So we'll go through all of them. But basically, like what I'm trying to get at with this is if you have portal hypertension, so again, the liver is like something's wrong with the liver, cirrhosis, something happens where the liver is just not getting blood through that hepatic vein over here. It's not getting it's not getting blood through there. What can happen if you can imagine this happening, where can the back flowing blood, oh my god, the back flowing blood, oh my god, tongue twister, back flowing blood go? And one of the main places that it goes, and again, it's because of this whole idea that it's very, very, very compliant. Veins are more compliant than arteries. They're kind of like not as strong. They're not pumping as much blood as arteries, like in that level of like intensity. So they tend to go back through the portal vein. If you guys saw that, but so that blood flow is going up, and then when you have something like portal hypertension, it can reverse and go in the other direction. And this kind of can give rise to these portosystemic anastomoses. So this is the picture from first aid, and there's a lot going on here, but I think that this is a good I think that this is a good kind of representation. And basically the idea behind this is that every portal vein is connected to some sort of systemic vein. So if you get the backup in the portal vein, it can go through the systemic vein. So for example, like here, so let's say we have the portal system, so we have some sort of portal hypertension. So the blood's going to start flowing back this way. That's what the red arrows are. It's going to flow back this way. It can go this way, for example, and then it can start going through this venous system, and that can cause like gut butt kaput. It can cause one of those pathology states. It can go back from this way. It can just go in this direction, and then it can go back to these veins here, and then similarly it can go this direction pathologically, which connects to these veins here. And again, if you're like, well, isn't that kind of draining in the correct direction? Yeah, but these veins, these systemic veins, are not like anticipating having to also drain portal blood that's backflowing. Like it's not physiologic. So it just kind of like anytime something's pathology, it just overrides the system. So this is an example of that. So we're going to go through the main three. So it's 1, 2, and 3. These are the three main types. And then number 4, this is treatment for it, which I'll go into at the end. Okay, so the first one we're going to talk about is this one. Sorry. This is where the left gastric vein, and also definitely know this anatomy. This is why I put it with the anatomy path, because it's like they can ask about which portal vein is it, which systemic vein is it. They can ask anything with anatomy with this. But for example, this would be the left gastric vein, which again is supposed to be going to the liver, but now it's not. It's going the opposite direction. So it's going away from the liver now. It usually has this connection, this anastomoses here with the esophageal vein. So again, shouldn't be going that direction. The systemic vein should be going to the inferior vena cava or the azygos vein. The portal vein should be going to the liver. So now we have this overriding of the system. So that's the first thing. It causes esophageal varices. So that's the first one we're going to be talking about. So esophageal varices, this is your left gastric vein from the portal circulation, anastomosing with the esophageal vein from the systemic circulation. So this one is going to be so within gut, butt, and kaput, this is going to be the gut. So this is gut in the little cute phrase thing. And it just means esophageal varices. And basically this is like the site of the anastomosis is in the esophagus, which of course it's in the name, esophageal varices. And basically what's happening when you see varices, you can kind of think of them as like hemorrhoids. That's kind of what varices are. It's just like turbulent blood flow that causes like a physical manifestation of like on the surface. So for example, if this is the esophagus should not look like this. It should be a nice hollow tube with like that's, like doesn't have bumps on it. So you can see all these bumps here. These are all varices. And just again, it's from that esophageal vein from the portal system, the left gastric vein from the portal system, basically like turbulently going back flowing through that esophageal vein from the systemic circulation, okay? And then, yes, the esophageal vein drains into the azygos vein, but this is how it looks. It kind of just looks like these bumps under the surface, and again, it's just like engorgement of the systemic veins because there's just so much blood there, okay? So that's the first one. Number 2, this is going to be, these are going to be your, the paraumbilical vein from the portal circulation, which is this one. And it has this anastomoses with the epigastric veins, which are these guys from the systemic circulation. Okay, so this is where the umbilicus is. So this is going to be right where the belly button is. And how that's going to look is kaput. So in gut, butt, kaput, it's kaput. And this leads to caput medusae. And so this is what it kind of looks like. Again, you have this backflow from the para-umbilical veins, from the portal circulation, kind of like turbulently going now through the systemic veins, which are those small epigastric veins, and they're everywhere in the anterior abdominal wall. Like I know in here, it's like, oh, there's only two. They're everywhere in the, just like there's multiple of these para-umbilical veins. That's why you see such a big area being affected by it. And it gets the name caput medusae, like the medusae, is because they said that this looks like Medusa's like snake hair. If you don't know the story of Medusa, Greek mythology, she looks at you, you turn to stone, but she had snakes for hair. So this is kind of like the idea behind it. It's like, oh, that looks like Medusa's hair. Sure. So that's the second one. And then the last one is down here. This is kind of like your true hemorrhoids, but this is where the superior rectal vein from the portal circulation, which is down here, this guy, it has these anastomoses with both the middle and the inferior rectal veins. So your middle here, and then your inferior rectal veins here, which are part of the systemic circulation. We get backflow, it goes through the systemic now, and then this is the butt in gut, butt, caput, and these are your hemorrhoids. So these are your true hemorrhoids, which honestly, all of these are technically hemorrhoids, but they're called hemorrhoids when they are like in the butt, basically. But the real actual name for them is anorectal varices, because it really happens at that area where the rectum and the anus kind of like switch, like where it kind of like switches from rectum to anus. Okay, so from here, this is going to be again happening at the rectum, like right at that like transition from the rectum to the anal canal. And this is going to be the superior rectal vein from the portal circulation is going to backflow into the middle and inferior rectal veins from the systemic circulation. And this is what it would look like. As you can probably tell, it looks kind of exactly just like the other types. It's just now we're in a different location. Okay, and then the last one that I wanted to talk about from here is the treatment for this. So if you just kind of think about like what the issue is the liver has some sort of block, like there's portal hypertension, right? Something's wrong with the liver where it can't get blood through it, so everything just backs up. So what they're trying to do is they're trying to kind of relieve some of that congestion in the liver. And what they do is they put this shunt in. So they put this literally like this man-made shunt in, and they're shunting blood from the portal veins in here to the systemic veins in the liver, basically. So you're going from like, I don't know, like the right hepatic vein. No, sorry, that's systemic. You're going from like the portal vein when it like one of the branches of the portal vein once it gets to the liver, and you're shunting it to that like central vein or that hepatic vein. You're shunting it, and then it's going to go to which again is not ideal, because the whole point of bringing stuff to the liver is to detoxify it. So you're kind of bypassing that whole process, but it's better than having backflow into the systemic circulation and getting these varices. Okay, so they call it TIPS, or transjugular intrahepatic portosystemic shunt. Ridiculous name. But basically the whole idea of it is it's within the liver, and you're shunting from the portal system to the systemic system, and you're just trying to relieve some of that pressure. Okay, so that's what TIPS is, and it's just a treatment for any of these varices. Okay, so that was that. Now we're done anatomy. So now I'm going to switch gears to talk about embryo, and then some of the path that can arise from embryo. Because remember, always the rule of thumb with first year is path is not as heavily tested as second year, but anytime they can ask path in the context of anatomy, in the context of embryo, in the context of something that they do ask you about first year, that's fair game. Okay, so I always try to do this, like explain the embryo and then go into like, oh, what happens if this goes wrong? Here's the pathology state that you can see. So I do have to go into a little bit of like developmental, like embryo, which is a little bit more repro block, but I'm not going to go into it in too much detail, just like the bare minimum of what's going to help you. And you will go into more depth when you get to repro. Okay, promise. But just to kind of explain it, like explain what happens, I do have to kind of go through this. So basically, most of the GI organs come from what's known as the primitive gut tube. And the primitive gut tube is basically from the foregut, like it contains the foregut, the midgut, and then the hindgut. So from this yellow, green, and purple, this is considered the primitive gut tube. This comes from the endodermal lining of the yolk sac. I'll show you what that means, but it's basically endodermal in origin. And all of these structures give rise to GI organs, but the gut tube gives rise to your foregut organs, your midgut organs, and your hindgut organs, which is pretty much all of the GI tract. There's little exceptions here and there, which I have on a future slide. But again, the three main regions of this become distinguishable around week 4 in utero. So just as a reminder, foregut, midgut, hindgut, this was from the anatomy slide. I did put little asterisks next to liver and pancreas because there are like parts of the liver and parts of the pancreas that aren't derived from this gut tube. But I have it on the next slide after this one, but they are still considered foregut organs. So these are non-gut tube derivatives. So everything basically just think of it as basically everything in the GI tract that's not foregut, midgut, hindgut. So for example, this bucopharyngeal membrane, which on this slide was right here, the bucopharyngeal membrane, which is in red right here, that's going to give rise to the oral cavity. And you're like, cool, that makes sense. It's close to the mouth. I can see that. The next one's the cloacal membrane, which is all the way over here at the end. Okay. Over here. And the cloaca is going to come up. I do mention it briefly when I talk about one of the pathology states, but the cloaca will come up again it'll come up in second year when you do like embryo path second year for the renal system. But that's the cloaca. It basically gives rise to the anal canal distal to the pectinate line. So remember we were talking about how, the above and below the pectinate line differ embryologically. This is why the anal canal before the pectinate line is considered a hindgut organ. So it's going to be coming from this hindgut, primitive gut tube. The anal canal distal to the pectinate line comes from the cloacal membrane. So it's not going to have like the similar features of the gut tube. That's why like lymphatics change, blood flow change, venous drainage change, everything changes between above and below the pectinate line. Then you have dorsal and ventral mesentery. This is like the mesentery that we know and love. Dorsal mesentery gives rise to the spleen, which is interesting. We'll kind of go into that a little bit more. Spleen is mesoderm, which is like really strange because all the other GI organs are basically endoderm. But the spleen is mesoderm, and it's not technically a foregut organ, but it is like a part of this GI tract-ish. I still don't consider the spleen a GI organ, but it's fine. No one really cares what I think, but the spleen is a very big immune organ. But again, maybe that's how you can remember it, that the spleen is like the odd man out because it's literally not a GI organ. But anyway, something interesting that I wanted to point out is we're going to go into like the pancreas. When the pancreas develops in utero, there's like two parts to it and then they combine, and both parts come from different like embryonic structures, which is really cool and interesting. And we'll go into that because it leads to a pathology state if the fusion is not correct or if the process of that happening is weird. But just notice like one of these buds comes from one type of mesentery, the other bud comes from a different type of mesentery. And then some of those ligaments we talked about last time, so the gastrosplenic ligament, splenorenal ligament, and the greater omentum are all going to come from dorsal mesentery, and I'll show you a picture of dorsal mesentery. And then ventral mesentery gives rise to parts of the liver. So again, the liver is also kind of stretching non-gut tube and gut tube. The ventral pancreatic bud, the falciform ligament. So remember the falciform ligament, this is going to be like your marker on the liver, and then the lesser omentum. And then types of mesoderm. So somatic mesoderm gives rise to parietal peritoneum, so that outermost layer, and then the splanchnic mesoderm is going to give rise to your visceral peritoneum, so the actual layers like lining the organs. And then I want to go into, again, you're going to go, like you will go into this a lot more in repro, like how does it go from a fertilized egg all the way up to like, all these like this like fetus that's in the body. So you will go through this process in repro, but I did want to show you that we're going to be talking about ectoderm, mesoderm, and endoderm, and you can start seeing these like very early on in development. This is like a zygote, and then it replicates a little bit, makes more cells, and then you get a blastula, and then eventually you'll get a gastrula. And gastrula, I always remembered the TRU. I was like, okay, well, if it's TRI, that means there's 3, and there's 3 layers. That's where you start to see these 3 layers. And this is like your germal tissue, like your germ tissue, ectoderm, mesoderm, endoderm. And kind of like like you will eventually, especially for boards, you'll have to know like what parts of the body come from ectoderm, what parts of the body come from mesoderm, what parts of the body come from endoderm. But we'll talk about it for the GI tract, like what parts of the GI tract come from ectoderm, mesoderm, and endoderm. But kind of to see this process kind of play out, and I will talk about this for another, I'll put this exact slide back up for another pathology state. But what I wanted to show you is this is kind of like, so we have the amniotic cavity here and we have the yolk sac. And then the yolk sac is pretty much has endoderm surrounding it. And then mesoderm is kind of in the middle. So all three of the, you don't have to know the different parts, but it's just mesoderm in the middle and then ectoderm on the outside. So I tried to color coordinate it. And basically how you go from this down to like an actual gut tube is you have what's known as these lateral folds. And I'm only mentioning it because it's a pathology. We will talk about it again. These lateral folds it's basically like part of the amniotic cavity is going to fold down, make these lateral folds, and eventually they're going to combine. So they're like swinging around, they're going to combine. You can see like there's like extrusion almost of like where the yolk sac is. And then eventually at the end of the day, you're going to have your primitive gut tube down here. And you'll still have ectoderm, mesoderm, and endoderm. So everything kind of in blue is still going to be that ectoderm. Everything in red is going to be like that mesoderm. And then anything in yellow is going to be your endoderm. So if just from this, you can kind of see if this is the primitive gut tube, you're probably like, well, most of the GI organs then are probably endoderm and like derived, and you'd be 100% correct. Most of the GI organs, like if not all of the GI organs, there's some exceptions again, like the spleen, but most of the GI organs are endoderm, and that's kind of like how the process happens. But in general, so this is what I meant, like when you're studying this for boards, it's kind of like, it's hard to memorize what every single organ came from, because it's not only like every organ, it's like, okay, well, the muscle of this organ came from mesoderm, but the epithelium of this organ came from ectoderm, and it's a lot. So in general, this is like how people think of ectoderm, mesoderm, and endoderm. So like ectoderm in general is like the skin, your nervous system. Mesoderm is muscle, your skeleton, like things, I always think of it as like things in the middle, which isn't great, but still muscle, skeleton, kidneys, the reproductive system, your spleen. And then endoderm is pretty much like a lot of the organs, but the digestive tract is considered endoderm, same with the liver, the lungs, the endocrine glands are all considered endoderm. Okay, so this is like very roughly in general. But for the GI, like the GI tract, which ones are relevant for the GI tract? Endoderm, and this is what's really confusing, and that's why I underlined it. The endoderm pretty much gives rise to all of the GI tract for the most part, but what they'll say is like, oh, it's the epithelium of the GI tract. But it's only the epithelium of the GI tract, because remember, ectoderm in general is usually the skin, which is made up of epithelial tissue. So just don't get confused with that. Ectoderm, because I remember like just when you're studying for boards and you're like, well, ectoderm is skin, GI tract epithelial is probably ectoderm, and it's not, it's endoderm, and it's pretty much just like everything in the GI tract is endoderm. Okay, so epithelium of the GI tract, all the mucosal glands of the GI tract, all the parenchyma of the liver, so parenchyma meaning like the actual functional units of the liver, all the parenchyma of the pancreas, like all that stuff, and then like your organs in general. And then for mesoderm, well, sorry, not your organs in general, that's from the gut tube, but this is like in addition to the gut tube structures. You have this, and then the mesoderm, the spleen, remember, spleen is just weird. It wants to be different. And then also, since mesoderm tends to be like connective tissue, muscle, things like that, you also have like certain layers of the GI tract coming from the mesoderm. So your lamina propria, which we talked about for anatomy, well, histo, your muscularis mucosa, your submucosa, things like that are going to come from the mesoderm. But the epithelial layer is endoderm. I know it's super annoying. And then for ectoderm, pretty much just for the GI tract, it's going to be the enteric nervous system. So like Auerbach's plexus, Meissner's plexus. So this is also something to keep in mind, even though like the submucosa, for example, and the muscularis layer of the are mesodermal in origin, the enteric nervous system, like those nervous system layers that are within these areas, are ectodermal in nature. And ectoderm, we're going to talk about this later, but if you have like a neural crest derived structure, it's usually going to be from ectoderm. And that's why like in general, the nervous system, because your neural crest cells give rise to a lot of like nervous system stuff within the body, and also not nervous system stuff within the body. They give rise to a lot of stuff in the body. But in general, I remember neural crest, and it's like neural, think of the nervous system, and I think ectoderm like almost immediately. Okay. And then here's just another picture. It's kind of showing the same thing. So you can see this image from here. Here's the yolk sac. This is like a side view. I kind of like this better rather than this, like a front view. It's like, what is happening? What is this? I don't even know what this is. This is kind of like to kind of visualize it better. So you have your amniotic cavity in blue, and then your yolk sac here. And remember, it's endoderm, mesoderm, ectoderm. And then from here, if you kind of zoomed in on the developing fetus, you would see like, you could kind of break it up a lot. Like remember the bucopharyngeal membrane, the gut tube, which starts from foregut, midgut, hindgut, and then the cloaca kind of like at the end. Okay. Okay, cool. All right, so then the next thing before kind of going into these pathology states is I'm going to be talking about rotations with some of these pathology states, because just like the heart, when these organs rotate, if that rotates incorrectly, like you can have a pathology state, just like, transposition of the great arteries was a problem with rotation. They transposed the pulmonary artery and the aorta. Kind of like you can get a similar issue with like the GI organs, like don't rotate correctly. So the first thing to talk about, the first one is the foregut actually rotates. So the foregut does a 90-degree longitudinal axis rotation. So if you imagine here that this is the foregut, so it'd be like that part of the gut tube. It literally rotates like if I need a pen. All right. So we have a pen here. We have a longitudinal rotation around it. It like would go in this direction. It's like, I guess like I guess that would be like a vertical type of, I don't even know. But it's just kind of doing this. It does it in like a clockwise manner. And then if you notice here, what you can start seeing is like the greater and lesser curvatures of the stomach. You're like, wow, that kind of is starting to look like a stomach. And then eventually the stomach can grow from this. So this foregut rotation basically establishes those greater and lesser curvatures, that the lesser is going to be more anterior and the greater is going to be more posterior just during development. The liver is going to be on the right side. And then the stomach, spleen, and pancreas are going to be on the left side. So that's kind of like what this does. It kind of like establishes these types of organs. This is way more the more commonly asked one. I highlighted this one. This is the more important one to know. This one you should definitely know. There's pathology with this one as well that we'll go into. But this is midgut rotation. Your midgut rotation is super weird. It like does this super odd thing. So we'll talk about it. But basically the midgut overall is going to make a 270-degree counterclockwise rotation around the superior mesenteric artery. Wild. So this is the developing stomach. So this would be like the foregut. The foregut's doing its 90-degree rotation, whatever. Here's your superior mesenteric artery that's developing. And then this would kind of be like your midgut. Remember, the midgut kind of goes from like the second part of the duodenum down to like the top of that like the proximal 2/3 of the transverse colon. So like, I know we can't see a duodenum here, but imagine it's like roughly around here. So like this is like roughly like a part of the midgut that's going to do this rotation. So what kind of happens is it does 2 rotations that in total add up to 270 degrees. The first one is this 90-degree rotation. So it like rotates 90 degrees. And then the second one is a 180-degree rotation. Here's a better picture of it. This is kind of like the one that I like seeing this better because I like seeing this ring. So for example, this happens, the first stage, which like the first rotation happens around week 6. So it's like right here. And to kind of like help you position yourself, this is the midgut. So the duodenum would be somewhere up here. This is the midgut. Here's the SMA. This blue thing is known as the umbilical ring. So remember, when a fetus is developing, the placenta it attaches to the umbilicus, right? So this is kind of like the start of the fetus. So this is a really weird thing because if this is like where the placenta is adding into, the midgut basically leaves. It's like, nah, I'm going to just try and go out of the umbilical ring, which is insane. So this is completely physiologic. This is normal. So what happens is this midgut herniates. So we'll talk about hernias at the end, but a herniation, I always tell people like, think of herniation as like something is somewhere it shouldn't be normally. So like if I have a hernia, that means my GI organs have went somewhere that they shouldn't have been. Like that's what we'll talk about with inguinal hernias, different types of hernias. It's like it moves somewhere and now it's somewhere it shouldn't be. So this is an example of it, but this is physiologic. So this herniation should happen, but now we have like a GI organ not in the abdominal cavity. So that's like it herniates out of the abdominal cavity and it leaves through the umbilical ring. And I get that this is really hard to visualize. I actually put a video in here because I think it's really like wild to see how this happens. But it leaves, so it literally leaves through the umbilical ring, and then it does this like 90-degree rotation. So it rotates 90 degrees, still counterclockwise. And the question is, well, why does it leave? Like, why, like it's developing, why is it leaving the abdominal cavity? And it's because the liver and the kidneys kind of take up all the space in the abdominal cavity, which I think is so cool. If I had to pick an organ, I'd probably pick the liver because it's just like, it's just commanded. It's just like, nah, you have to leave my abdominal cavity because I need to develop. And I'm like, that's so cool. Sorry. But so basically with the midgut, it leaves so the liver can grow, okay? And then it kind of finishes its development outside and then back in, then it comes back eventually. It's like, all right, liver, you've had your fun. But for like a good 4 weeks, it's just developing not in the abdominal cavity, which is wild. So that's the first stage. I know I have stage 1, stage 2. I only think of them as 2 stages. Like I think that's fine. It's just more so where did these rotations happen? But technically, yeah, I guess there's 3 stages, I guess. But so it leaves, it rotates 90 degrees, it does its development, like all these things start happening. You start seeing like little structures start to form. And then around week 10, it comes back. So it literally it unherniates. I guess if that's a word, it'll like unherniate, it'll come back to the abdominal cavity, and then it'll rotate an additional 180 degrees counterclockwise around the SMA. So again, kind of hard to see, but this is like where it's starting to come back now. See how it's like, it's getting shorter. It's starting to go back a little bit. And then you can see all of a sudden it's like, oh, that kind of looks like a transverse colon. Like you can start seeing like these structures start to develop. And then like at the end of it, you can see clearly like your small intestine's in here. Here's your large intestine. So in total, it's rotating 270 degrees. All right. So this is the video. I don't know if this is going to work, but we're not going to watch the whole thing. I just want to go to, yeah, so this is the part I think is absolutely wild. And if you guys can't see anything, I promise I'm seeing something. So just watch. I put the link here down at the bottom, but just watch it. The sound's off. So this is the developing fetus, right? So this is where the umbilical, like this is where the placenta adds to. It's in the umbilical region. So this is the umbilical ring here. Here's your midgut. It leaves. So this is around week 6. It literally leaves. It goes like basically into the placenta, which is wild. Does its first 90-degree rotation. And then we have about just 4 weeks of development while it's just chilling outside of the abdominal cavity. Because again, this is the fetus back here, and you have this development happening out here. Again, wild. Okay, so now it's finishing up. It's going to kind of come back, and then when it starts to like come back through, now it rotates that additional 180 degrees. And that's where you really start seeing like the small intestines here, the large intestines here, and then there you go. And then that's your final like product. And then it's back in the fetus. Okay. So that's midgut rotation. It's relevant, but basically what it's going to establish is the cecum is going to be in the right lower quadrant. And then it also does this additional thing. The fact that it's just rotating in general does this additional thing where it fixes what's known as the duodenojejunal flexure. Absurd name, but it's basically where the duodenum switches, like it flexes, right? So it has a little bend. That's what flexures are, little bends. It switches now to the jejunum. Right here at this flexure, it will now attach to the posterior wall, like to the vertebra on the back. And it does this with what's known as the ligament of Treitz. So this ligament of Treitz, once it's kind of here and it rotates properly, it kind of holds it in place. And I only point it out because it's like, sometimes it's like, oh, like, what's this ligament called? It can just be like an anatomy landmark. It like doesn't do anything. I remember like, I only saw the ligament of Treitz when I was in like the anatomy lab doing like those anatomy dissections with Dr. Garcia. He's like, this is the ligament of Treitz. And I'm like, duodenojejunal flexure, blah, blah, blah. Okay, but this is what's kind of attaching it to the posterior wall. Here's another picture of it. I don't know why it's so blurry, but this is your ligament of Treitz. So it's just this ligament, again, that's going to connect basically the duodenojejunal flexure to the back wall. And you can only get this ligament. This ligament will only form if you have proper rotation, proper midgut rotation. Okay, so some of the paths. So the first path is going to be the congenital umbilical hernia. This is so common, super, super common. I had one of these when I was born, and it went away all on its own. But this is basically like when the midgut herniates through and then it comes back, the umbilical ring should close. Like it really should close. Sometimes it does, but it doesn't do it like perfectly. And you can kind of see here, it should like close off like this. And if it doesn't happen, then you can have the intestines herniating through where the umbilical like region is. Usually, again, so if you have a baby born with a congenital umbilical hernia, it usually, you don't do anything for it. Like no one did anything for mine. It just kind of went away on its own. And it looks totally normal after. So usually it should unherniate on its own. You don't need intervention. But if you see this, like intestines through the belly button in a newborn baby, you're like, okay, that's normal. Okay, so that's the first type of pathology that can happen from this. The second one is midgut malrotation. So the midgut rotates, it should rotate 270 degrees counterclockwise, but if something goes wrong with this rotation, malrotation, it rotates bad, that's when you can have this pathology state. So when the midgut improperly makes that 270 counterclockwise turn around the SMA in that last stage of development, and not the third stage of rotation, that third stage, like the final stage basically of like abdominal development. So this is where people get kind of confused with midgut malrotation and then something else we're going to talk about. It's called volvulus. Volvulus is like when like something leads to straight up obstruction. So you can have midgut, and we will talk about this when I talk about volvulus, but midgut malrotation can be with volvulus or without volvulus. And usually in test questions, it'll say like, oh, this is midgut malrotation with volvulus or without. So they can present a little bit differently. I mean, imagine like having a bowel obstruction versus not having a bowel obstruction. Like those symptoms are going to be like very different. If it leads to bowel obstruction, that's super dangerous. You can lose the bowel. Anytime you have a bowel obstruction, it's really bad. But it depends on how it malrotates. Like how does it do a malrotation? Does it just counterclockwise turn 250 degrees? Because if so, it's probably not that big of a deal. But if it rotates clockwise, or it rotates in the exact opposite way, or it flips over and does something weird, that's when you can start seeing like the volvulus. And then you can see what's known as LAD bands. So LADD. This is like a buzzword. Here's the buzzword B. Again, can see them. You don't see them in every case of midgut malrotation. They're not something that you can see that you like. They're not something that if you don't see them in a vignette, it's like, oh, this is a midgut malrotation. They might be there, they might not be there. Just like volvulus might be there, volvulus might not be there. Okay. And I'll show you what LAD bands are. But these are basically like these fibrous bands that form since the midgut's not where it should be. You can kind of think of it as like almost like it's not the ligament of Treats, but you know how the ligament of Treats forms when it properly rotates, and it's like, okay, here it is. This is like the exact opposite thing. It's like the midgut malrotates. It rotates in some sort of weird way, and the body's like, I don't know what this is, but I'm just going to make like these bands and keep it in place. And those are bad. Those are pathologic bands. They're called LAD bands. And so, for example, if you see LAD bands, this probably means like it rotated like the opposite direction of how it should be, or it just rotated like really weirdly. So sometimes what they'll say too is like the small intestine is entirely on the patient's right and the large intestine is entirely on the patient's left. And if you can envision that in your head, you're like, that's not what should happen. But here's a picture of it. So here's midgut malrotation. So for example, it like herniates through, weird things can happen. Here's your large intestine being entirely on the left, your small intestine being entirely on the right. Remember anatomy brain, right, left. This is like your straight up volvulus, which we'll talk about, but see how when it rotates, it like just like like the large intestine is like, looks like it's squeezing part of the small intestine. That's not great. And then here's an example of midgut malrotation with LAD bands. And again, it's just these fibrous like ligaments basically that are like, all right, it's just like, I'm just gonna form here, I guess, like whatever. I don't know what this is supposed to be, but same thing, it's kind of the same thing in all of these is the small intestine is entirely on the right and the large intestine is entirely on the left. So here's another one. So you can see like if they give you like an x-ray, here's the entire small intestine. And it's like, again, why is the entire small intestine on the right side of the body? Like that shouldn't be how it is. But look for these. Usually they'll mention something about LAD bands. If this is the case, this is the type of malrotation they want you to think of. Again, these are going to be your buzzword for that. they might not call them lad bands. They might do it first year, but like they won't do this on boards. They'll just say like there's like these fibrous bands that are connecting like the liver to the colon, like that, or like yeah, like the liver to the colon, the liver to the small intestine, something like that. Those are lad bands. So again, malrotation with or without volvulus. This does not look like volvulus. This does not look like some sort of obstruction. But volvulus is, like I said, it's kind of like where you have this obstruction of some sort. So this is like when a portion of the bowel, when it twists around its own mesentery. So if I go back really quick, remember mesentery is going to be all this, like if this was colored in, this would all be yellow, right? Because it's kind of like holding these organs in place. That's what mesentery does. So part of like the colon, for example, would wrap around its own mesentery and just like lead to that like clear obstruction. Okay, so this can lead to obstruction and infarction. This is why it's bad. A lot of the times bowel obstructions lead to infarction. So like death, like loss of tissue, like literally a heart attack, but in your colon or in your GI tract. And then something I want to put you guys onto now is you can literally cross off answer choices based on if they tell you if there's bilious vomiting or non-bilious vomiting. So anytime like it would be bilious versus non-bilious, I point it out. And what this means, bilious versus non-bilious, remember we talked about last time how the second part of the duodenum is here. Here's your pancreas. The head of the pancreas is here. Oh, I didn't do that. That's fine. You guys know what I mean. And then the common bile duct kind of comes in. So the common bile duct kind of comes in through the pancreas. All right, let me extend the pancreas. Okay, sorry. So the common bile duct comes in. It empties into the duodenum. The main pancreatic duct comes in and enters into the duodenum. This is at the ampulla of Vater. So remember ampulla of Vater, this is the location in the small intestine that's receiving like the main pancreatic duct as well as the common bile duct. And remember the sphincter of Oddi is on the pancreas. That's what's controlling. It's a sphincter, so it's controlling the release of those pancreatic juices and whatnot. So if you have something like midgut volvulus, midgut, just by definition, is going to be after the second part of the small intestine, right? It's the second part onwards is what the midgut is. So anytime you have midgut, like malrotation leading to volvulus, it's going to be, after, where's my little, is this it? Yes. It's going to be after where the bile comes in and where the pancreatic juices come in. So with that being said, it's going to get blocked. Like these pancreatic juices, these bile juices are going to get blocked because there's literally an obstruction here because of this malrotation that happened and it curved around itself. So the food that you swallow is not going to get past this point. So you're going to throw it up, or the baby's going to throw it up. And when they do that, it's going to be bilious because of bile. Bile is entering into the small intestine before the obstruction. So when you throw it back up, there will be bile present. Okay, and there are some pathology states that happen before the ampulla of Vater, maybe like right at the ampulla of Vater. We'll talk about that one. But bilious vomiting usually means it's after this location at the ampulla of Vater. That's where you have this obstruction. Okay, so midgut volvulus, midgut by definition is after the ampulla of Vater, and then boom, you can get bilious vomiting. Okay. So this is more common in infants and children. So it's really more of like a congenital kind of embryo thing. This is the one that malrotation can lead to. So this embryologic issue of midgut malrotation can lead to midgut volvulus. And again, this is what I'm saying. This is the one that is going to be in kids when you're thinking of like embryo path. It's this type. But you can have volvulus in like elderly people, just getting old, kind of things are moving around a little bit. You can actually have sigmoid volvulus. So sigmoid volvulus is where the sigmoid colon is, which remember, if we have the colon, ascending, transverse, descending, sigmoid, and then rectum. So it's on the right side, and then anus. So it's on the right side. This part, so the sigmoid colon, can basically rotate on itself. Like, don't know why, it's just something that can happen in elderly people. You kind of see it in like more elderly people, and people remember that with saying like elderly Mr. Sigmoid. I use that as well. I think that's hilarious. I imagine like this elderly man with a top hat. But anyway, so his name's Mr. Sigmoid. So that's a sigmoid. So that's a little bit different. I know it's not really midgut anymore, but it is like usually just where the sigmoid colon is. So that's why they call it sigmoid volvulus. And how you can see this is they'll show you an x-ray and they say it looks like a coffee bean. So when the sigmoid colon rotates around itself, this looks like a coffee bean. Medicine will just ruin all foods for you, right? It really will. Just, why you gotta call it a coffee bean? But that's what they're saying it looks like. It looks like a coffee bean, and it's on the left side. So here's left, here's right, because again, the sigmoid colon is on the left side. This is like a weird kind of picture. It's still on, it's from first aid, but it's still on the left side. They just didn't include the right side of the colon in this picture. Okay, so here's your coffee bean sign. That's your sigmoid volvulus. Okay, but that's not your congenital one. I just wanted to throw it in there. And then something that makes volvulus tricky, and this is according to Boards and Beyond, because again, I'm not a clinician, I don't know this stuff, but according to Dr. Ryan from Boards and Beyond, he says that if you do an abdominal x-ray, it can be normal. So if you do, that's why like this coffee bean sign is really just for this sigmoid volvulus. If you do an x-ray for midgut volvulus, it might be normal. And this is like, they're trying to get you, basically. They're like, oh, like it sounds exactly like midgut malrotation leading to volvulus. And then they're like, you do an x-ray and it's normal. And you're like, why is it normal? Shouldn't there just be like a massive bump of some sort because it like rotated around itself? But it, like Dr. Ryan said, like they can be normal if you have midgut malrotation and leading to volvulus. So don't use that as like a ruling out. Don't rule out midgut malrotation with volvulus because they say the abdominal x-ray is normal. Okay. They really only use these abdominal x-rays for the sigmoid volvulus, adults that have volvulus. So this is my just thing, like just don't rule out malrotation if the abdominal x-ray is quote unquote normal. It's them trying to trick you. It's them trying to get you, but don't get got. All right, next one is going to be intussusception. So intussusception is literally telescoping of the bowel, which sounds really disgusting, but think of it as like literally like a telescope. You know, when like people carry around little telescopes. Well, I don't carry around a telescope, but if someone carried around like a telescope with them and then they're like, oh, I want to go see the moon, they have to like extend it, right? And then when they're done, they restack it. But there's like these, do you know what I'm talking about? There's like these little layers, and it's like, it goes through this layer and then it goes to the next layer and then it goes to the next layer. Like that's what they mean by it's telescoping. Like it's like this further part comes back into like this bigger part that captures it almost. I don't know if I explained that correctly. It's just, imagine, it's going to be disgusting, but imagine this is the bowel. Imagine you would like open this up to look at the moon now. That's like telescoping. It's like going into a part of itself, basically. It's like going into it. This is not a congenital anomaly. This can just happen in kids, but I have seen intussusception questions like as a pathology asked. So I'm like, all right, it's not technically embryo, but it's fine. We'll talk about it. So it's telescoping of a bowel segment into itself, and it usually happens right where that ileocecal junction is. So right where the ileum of the small intestine enters the cecum of the large intestine. So we have our cecum, ascending colon, transverse, descending, blah, blah, blah. And then remember, we have our small intestines in here, blah, blah, blah. And then right here where it goes from ileum into the cecum, that's usually where this happens. And that kind of makes sense. You're going from like a small intestine, which is a different histology, different type of, bowel, into a different type of bowel, a large intestine. So there's just a little bit more like, not friction, but there's just a little bit more something there. So that's usually where this happens, is because of like, I think that transition point. And the buzzword for this is going to be current jelly stools, which is disgusting. Current jelly is like this really dark red jelly, basically. Again, it's going to ruin food for you. Medicine ruins food for you. But that's what they say it looks like. It looks like current jelly stools. And again, it's just because like there's bleeding that happens here, like food can't get through, like just, yeah. So you see dark red in the stools. But a lot of the times they will say current jelly. This does not happen all on its own. You do need what's known as a lead point. So a lead point is kind of like this. Like you kind of need something that triggers this intussusception, this motion. And the most common cause in children is what's known as Meckel's diverticulum. You may come across Meckel's diverticulum this block. I didn't go into it into this PowerPoint, but just keep in mind that the most common cause in children is Meckel's diverticulum. Appendicitis can also be like a lead point for this because your appendix is right where the cecum is. So it's like also acting as like a lead point. Actually, maybe I do talk about Meckel's diverticulum. I don't remember, but I may or may not talk about Meckel's diverticulum. It's just something you probably will see, and like it is a path thing, but I don't cover it in this PowerPoint. It's the most common cause of it. And for me to explain what a lead point is, I think it's easier to explain it using a tumor, just because I think that'll be the most helpful to understand it. But it's basically like if you have a tumor. So in adults, they can get intussusception. Usually it happens because of a tumor of some sort. If you have a tumor, it's basically like you're making, like, let's say let's say you have a small intestine, large intestine tumor, a colon tumor. You have something like that. It's making whatever segment it's on heavier. So now it's like, that's like your lead point almost. Like if something goes wrong or something happens, now it's like there's just more of it. And it's like things are just going to move around. It's like inertia almost, right? It's like if you, like something that's just moving, if you have something heavier and it's rolling down a hill, it's going to roll down faster than something lighter. I think. I don't know. Physics was a long time ago. But that's kind of the point of it. Like this lead point, it's like something's triggering this movement, like this intussusception, this telescoping movement. Okay. I'm gonna stop talking about it, but that's what intussusception is. It's very painful. Intussusception is super, super, super painful. Usually in vignettes, I can't remember if I put an intussusception question in this PowerPoint, but usually they'll say like the kid is in so much pain. They try to put they're lay on their back and they try to put like their knees up to their chest just to kind of like relieve some of the pressure in the abdomen. Like they're just in a lot of pain with this. But a lot of the times with intussusception questions, they'll give you symptoms of having a Meckel's diverticulum. And they're not trying to get you to pick Meckel's diverticulum. They're trying to get you to pick intussusception. But usually the most commonly it's caused by Meckel's diverticulum. So it's kind of tricky. Maybe like towards the closer to your test, I can find a good question because it's a lot. They like to ask about it because it's a lot. It's like they describe Meckel's diverticulum, but then they ask you about intussusception because it's the most common cause of it. Okay. Cool. All right. So that's intussusception. And then, oh yeah, you can also see what's known as a target sign. Sometimes they call it a bullseye sign. I like target better on ultrasound. So this is ultrasound. They would just like go to the region that hurts. Usually it's on that right side because again, it's that ileocecal junction. They'll go on that right side with an ultrasound and you see like, this should not be here, but you see basically like these concentric rings and it looks like a target. And again, this is the bowel that has telescoped into the second part of the bowel. It like went into it. Okay, so next are ventral wall defects. And ventral wall defects are not just for the GI tract. Ventral wall defects can come up in pulm, they can come up in cardio, they can come up in renal, like they can come up anywhere. It's like, and I'll show you again. We did talk about the ventral wall. I just didn't tell you it was the ventral wall. But basically what happens is that whole process of developing from like the amniotic cavity and the yolk sac all the way down to that gut tube. If something goes wrong with that folding of all those membranes, you can get entire areas of this baby's body that's just open, which is insane. And I have some pictures to show you. But for example, like if you have a rostral fold closure issue, so the rostral folds are the ones going to be closer to the sternum. If those don't fold correctly or they don't completely fold, you can see sternal defects, so issues with the sternum. And what this leads to is known as ectopia cordis. This is where the heart is outside of the body. Insane, because again, the sternum's not there. So the heart just kind of like, it's like, hello. So it's just like outside of the chest. Insane. You'll probably do this in cardiopath second year. The one that's relevant for you guys this block is lateral folds closure. And remember I mentioned the lateral folds. I have the picture back to show you again. But if those lateral folds don't completely, so they come down, right? And if they don't completely close all the way, the abdominal contents can come out. Like the baby can be born and just the abdomen is just out of the body. There's two types. One's called omphalocele and one is called I can never say this, gastroschisis. Gastroschisis. Okay. And then if you have a caudal fold closure issue, so usually like down where like the cloaca is, like all the way down there, like that area, if the folds don't happen there, the bladder can not be in the body. So they call that bladder extrophy. bladder extrophy, that's the word. And again, it's the same thing. Bladder is just not in the body, it's outside of the body. And you'll do that probably next year in renal. Okay. So it's just like when you have issues with the ventral wall when it's developing, if you have a closure of any of these folds, rostral, lateral, caudal, you can have organs that are now outside of the body, because the whole point of these folds is to keep everything like in the body. But basically what I was talking about were these lateral body folds. So here's your amniotic cavity, your yolk sac, and then this whole process happens where these lateral folds start to come down, and see how they come kind of wrap all the way around, and eventually they close. And they make this gut tube inside of the body. But sometimes like this just won't close. Like let's say we end here before we get to like the gut tube being here. Now part of the abdominal cavity is outside of the person's body, of the baby's body. And that's what omphalocele and gastroschisis is. Okay? So literally that exact same thing. Like I said, omphalocele, gastroschisis, definitely know the difference between these two. They will probably, you 100% will get a question about one of these or both of these. This is probably the most high yield, I would say. But for example, the main difference between the two is omphalocele, there is a membrane that's covering the organs. So like, let's say this is small intestine, it's going to herniate through, where those lateral folds should be. So they herniate through, but they're covered with like a membrane. It kind of looks like it's like there's like a film over it. Versus gastroschisis is literally like it's like you're strewing like bowel out through like where the umbilicus is, which is wild. So it gets like just extruded through, and I have pictures to kind of show you, but there's no membrane covering it. It looks just like straight up bowel outside of the body. So this is omphalocele. Sometimes people ask, oh, well, how can I tell the difference between this and like a congenital umbilical hernia? You can tell the difference. A congenital umbilical hernia is just like, it looks like your belly button is just protruded out a little bit, but everything looks normal. It's just like the belly button's out. This is like you have a full GI tract outside of the body. Like it looks very different, but it is covered by this membrane. So this is omphalocele, failure of the lateral walls to migrate. It's literally just this, like it's kind of stops here where the umbilical ring is, and they don't completely close like this. So this has persistent midline herniation of abdominal contents into the umbilical cord. And hopefully this makes sense, into the umbilical cord, because it's directly through it. And you can see it here, like this is kind of like where the umbilical cord is, where these, the red and the blue, red, blue, it's just directly through it. Okay, and gastroschisis is a little different, but the omphalocele directly through the umbilical cord. It's in that umbilical cord region. It's covered by peritoneum. So a lot of the times they don't tell you, oh, this is, something covered by peritoneum. They're not going to say that. They're like, oh, like the abdominal contents were surrounded by like a light gray, shiny sac or something like that. People remember this with like abdominal contents are sealed for omphalocele in the letter O. They're like sealed in an O, I guess. Sure, it's like in a sac. This will come up in second year repro, because this is associated with like Down syndrome and like some other congenital like trisomy issues that you will cover in repro second year. And you're like, oh yeah, omphalocele, it makes a comeback. But a lot of the times this is like for some reason it's just like associated with some trisomy like genetic diseases. And then gastroschisis is extrusion of the abdominal contents through the abdominal folds, but typically it's not directly through that umbilical cord. It's like to the right or to the left of it. So if we go back to this one, you can kind of see like it's not directly through here, like through this umbilical cord. It's like to like the left of it or to the right of it. It's just off to the side of it. It's still where those lateral folds are not, it's still in like that ventral wall, but it's not directly through. So that's like another difference. Has nothing covering it. Like I said, it's just straight up bowel. It's insane to see. And like people say, the guts come out of the gap in the letter G. Whatever works for you. This is not associated with any sort of chromosome abnormalities. Again, it's just something that happens. And then there's a favorable prognosis, which is good because you just kind of put the small intestine back into the body, and then everything's fine. Okay. So here's like a compare and contrast. Definitely know the difference between these two. If I didn't emphasize that enough, just know every which way they can ask questions about these two. So, for example, here would be like a gastrocecious, where it's like either to the right or to the left of like where the belly button is. There's no peritoneal covering, there's nothing like that. Versus omphalocele, it's physically protruding through where the umbilical cord is, and then it is sealed with this like peritoneal amniotic like just some sort of covering is covering it. Okay, this is the one associated with your like your trisomy disorders. This one is not associated with trisomy disorders, so gastrocystis has like a good favorable prognosis. Okay, the next herniation, because we just love doing herniations today, is congenital diaphragmatic hernia. You guys might have done this in POEM, possibly, but this is where basically the diaphragm fails to close. And I know we didn't go into diaphragm embryo, it's just not super relevant in my opinion, but the diaphragm itself does not completely close. So now there's just room, and the bowel's like, cool, I'm just gonna herniate through here for some reason. But specifically, sometimes they'll tie this into anatomy, and it's like, okay, well, like what part doesn't close completely, like what part of the diaphragm doesn't close completely, and usually it's the pleuroperitoneal membrane, so where the peritoneal cavity kind of meets the pleural cavity, so it's like kind of right, like it's right near the lungs. Okay, and this is like herniation of stomach or intestines through a posterolateral defect. This is another thing they like to ask. They're like, what type of, like, where in the diaphragm does it like to kind of go through, like where is this failure of the pleuroperitoneal membrane that doesn't fold correctly, where is it located? It's located in the posterolateral part of the diaphragm. Typically it happens on the left side. Again, the liver protects the right side. The liver just controls the GI tract, clearly. But so typically it happens on the left. And then it is seen in infants, and the mortality rate is high because you have left lung hypoplasia. So we did talk about lung hypoplasia. We talked about it with Potter sequence. It's one of those things that can happen if you're not swallowing amniotic fluid. Your lungs don't really develop properly, and it's like they kind of just remain really, really small. So it's almost like the baby's born with one lung. So you can imagine that mortality would be pretty high with that, because of this reason, because the left lung just doesn't really develop. Okay, next we have the transesophageal fistulas, or TEFs. This is also something that might come up again in POEM second year, because we do kind of have that component with the trachea, which is technically the windpipe, so it's technically POEM. There are many types. You don't have to know them all, again, according to me, in my opinion, but sure, know them all. The more the merrier, right? The more you know, the better. But like, just for purposes of this exam, I don't think you need to know them all. The most common ones that I believe that you should know, and absolutely like, know them all, honestly, but like, you don't have to know them in as much depth as this one. Like, you should be able to like almost be able to point this one out if you see it in like a vignette. So the most common one is called esophageal atresia with distal tracheoesophageal fistula. So a lot of terminology here. We'll talk about it, but atresia, we are going to talk about some atresias. Atresia just means it's like you have like a like a tunnel. So like, let's say normally you have a tunnel, so it's going, and atresia is when the tunnel stops short. So it's like you suddenly stops and you're like, oh, I should have like 2 more miles of tunnel left, and you don't. That's an atresia. It's kind of like, they call it like a blind pouch, because it turns into like a pouch rather than a tunnel. That's how you can think of it. So imagine the esophagus having a blind pouch instead of a tunnel. You're not going to get food into the stomach. So you have what's known as esophageal atresia. So you have the esophagus just stops, and then the stomach just is like, oh, okay, sure. Like, there's no connection here. But then you have what's known as distal tracheoesophageal fistula. So distal means like towards the bottom of whatever organ we're talking about. So we're still talking about the esophagus. So towards the bottom here, you have a fistula to the trachea, which would be, in front of, which I can't draw on here, but whatever. I'll show you a picture. So the trachea and the esophagus now have this weird connection between the two. That's called a fistula. Anytime you see the word fistula, it's like an abnormal connection. So this implies that two things are connected that shouldn't be connected. Okay? All right. So we have esophageal atresia with distal tracheoesophageal fistula. So we have an abnormal connection now between the esophagus and the trachea. Just imagine what that means. That I'm basically telling you that food can't get to the stomach, so it can't get to the small intestine, it can't get to the large intestine. Not only that, food has this direct pathway to the trachea, which go to the lungs, which go to the bronchi and then to the lungs. So that basically means this baby's going to swallow food and then it's going to end up in the lungs. Really bad, really, really bad. So a lot of the times, again, they won't really explain this to you, like what this anatomical feature is, because they know that gives it away. Instead, what they'll do, and you might even have like a baby that has esophageal atresia with distal tracheoesophageal fistula, you might have a case with that in PBL. They basically they'll give you some things that kind of hint to it without telling you what it is exactly. So for example, the first thing, this kind of ties into like the Potter sequence we talked about last block. There's polyhydramnios. Why would there be polyhydramnios? The baby can't swallow, the fetus can't swallow the amniotic fluid. And remember, because again, the esophagus is empty. Like it's like there's no connection with the esophagus to the rest of the GI tract. So it's just like, oh, I can't swallow this. So it just doesn't swallow it. So you get polyhydramnios. At birth, there's cough, there's like a lot of drool, just a lot of secretions. There's cyanosis. Again, cyanosis hopefully makes sense because it's like there's a connection with the esophagus and the trachea. If you try to feed the baby, so the first time you ever try to feed the baby, food does not go down. It's like immediate. It chokes, it vomits, it throws it up, like the very first time you feed them. And I'm emphasizing this because there are some pathologies we're going to talk about in a little bit. It's like, oh, like maybe after 2 weeks, now they start throwing up, they start vomiting, they start doing this stuff. This would be non-bilious vomiting, right? I didn't put it on here, but definitely non-bilious. We're up in the esophagus. That's like the level. We're clearly nowhere near the duodenum here. So we'd see non-bilious vomiting, choking. It's literally because you're giving them food, it's going to the lungs. You'll see air in the stomach, which again, you have this abnormal connection between the trachea and the esophagus, or that might not be applicable with this one specifically, but you can see air in the stomach because of these abnormal connections between the trachea and the esophagus. And usually with the cyanosis, they say cyanosis is secondary to laryngospasm. And all they really mean by this, laryngospasm just means like the larynx. Your larynx, which is like the opening to where the trachea is covered with an epiglottis. And your epiglottis is the little flap that, like, when you swallow food, the epiglottis goes over the trachea to be like, hey, I don't want you to swallow this. Like, I don't want you to aspirate this. I don't want this to end up in the lungs. So you have like your esophagus, you swallow, there's like this little flap that goes over the trachea. And it's really only when you're swallowing food and eating food. This instance is basically like the baby always thinks it's going to be aspirating food constantly. So this epiglottis is just like almost blocking off the airway entirely. That's kind of basically what's happening. And that's why they get cyanotic. That's why they basically turn blue. But the real kicker, the real thing that gives it away is you try to give the baby an NG tube, so a nasogastric tube, right? You try to put like a tube in from the nose that goes into the stomach to be like, we need to feed this baby. Like, I don't know why this baby's vomiting. We need to give it food. So they try to put a tube in the stomach to just give it food, like just regular, just whatever food. And you can't get it down there. And again, you can't because there's a blind pouch to the esophagus. There's no connection from the esophagus to the stomach. Okay. So this is what it looks like. So here's the esophagus normally, here's the trachea normally, totally fine. There might be like this gastric bubble. So this gastric bubble here, which is normal to an extent. And then you can see all these different types. So you can see pure esophageal atresia or stenosis. So remember, stenosis is just like with the valve stenoses from cardio. It just means like a narrowing. So I would actually say that this would be like a true kind of stenosis. Like a stenosis. Atresia is like this would be completely blind pouched off. The next one is what they call pure transesophageal fistula, which is H-type because it looks like the letter H. 1, 2, 3. They call that H-type. And this is just basically like you would have tons of air in the stomach basically because you would swallow air, like you'd breathe, you don't swallow air, you'd breathe air and then it would just go through like this abnormal connection and it would go into the stomach. And then here's the most common one. So esophageal atresia with distal transesophageal fistula. So we have our esophageal atresia, and then we have that additional transesophageal fistula. So that abnormal connection between the esophagus and the trachea, which absolutely should not be there. So again, kind of the same thing. Anytime you're breathing in, it can kind of, some of that air can go into the stomach. So you'll see a lot of, like you'd see like a prominent gastric bubble. But not all of the types have this prominent gastric bubble. Some have them, some don't have them. It's really not great. Like, don't use that like as the only diagnostic method. Really use it for more of like the first feed, they vomit. They're cyanotic, like little things like that. Okay, makes sense? I like literally ask as if someone can answer. Okay. Okay, so then we're gonna kind of switch gears now and talk about more of like other types of atresia, as you can see. So the first one, this is the most common one. This is like the more important one, I think. It's called duodenal atresia. Your duodenum ends in a blind pouch. So how they say it is like the duodenum does not canalize. And I would be familiar with this word because this is kind of what they'll say. And what they mean by that, it's kind of like when I was trying to explain it as like using a tunnel. Like if I want to make a tunnel, I have to like make a canal, right? Like I have to like dig and use my shovel to make this tunnel. And so it's basically saying like if I'm not making a canal, I'm not making a canal for the tunnel. It had failed to canalize. I failed to make that tunnel, basically. So it's the same thing. It's just atresia, but now we're in the duodenum. So you can imagine like we have the stomach and then we have the duodenum and then it ends in a blind pouch. So it ends in a blind pouch and then the second part, like that's just not connected anymore. You see bilious vomiting. So bilious vomiting, this is happening after the ampulla of Vater. So this usually happens around, like probably right around where the ampulla of Vater is, but you usually see bile in the vomit. That will help you, especially with a newborn baby. And you're like, is this a transesophageal fistula? Is this duodenal atresia? Like, what is it? Use that bile in the vomit to help you. This happens as soon as the baby is born. Again, I'm emphasizing this because there's other ones that take a little bit of more time to develop and you start to see the vomiting. I believe we'll start talking about it in like 2 slides. But this one is like you feed the baby, kind of the same thing, like they vomit it. So it's kind of similar, like you give them their first feed and then they vomit. And you're like, well, again, transesophageal fistula, what is it? And usually you can use that vomiting to help you. Another thing that can help you is this is associated with Down syndrome. So if you have a baby, sometimes they'll like give you little things in a vignette that like will be like, oh, this baby sounds like he or she has Downs. That can help you be like, wait, this probably is duodenal atresia because this is associated with Down syndrome. And then the other thing that can help you is sometimes they'll do like an abdominal x-ray to see what's going on, and they see what's known as a double bubble sign. Love that. So the double bubble is basically like the duodenum bubbles because it's a blind pouch. So like food's going to end up there, but it's going to bubble. And then the other one is the stomach really, really dilates. And the reason it just doesn't look like a single bubble, that's just like a big, giant, massive thing, is because remember the stomach does have the pyloric sphincter right here. And remember the pyloric sphincter controls food leaving the stomach and going to the duodenum. So maybe it allowed some to go in here and then the duodenum gets really big and then it's like, oh, we can't have no more, like don't let anything else come through here. So then the stomach gets really big and it enlarges. So that's your double bubble. One is the duodenum, one is the dilated stomach. Okay, so that's duodenal atresia. Next is going to be jejunal or ileal atresia. They're kind of like the same thing. Like it's just like you can have the same thing. It's just, is it happening in the jejunum or is it happening in the ilia? Definitely lower yield. I would say duodenal atresia is like a lot more important than these two, but I still wanted to mention it. Basically what happens here, like how does this even happen? It's not associated with Down syndrome. It's just like the SMA during development can become ischemic and then it can lead to necrosis of parts of the fetal intestine. So that can be like the jejunum, because remember the SMA is doing anywhere from like the last part of the duodenum all the way down to like the transverse colon, right? So like if you get disruption where the jejunum is, you can get jejunal atresia. If you get disruption where the ileum is, you can get ileal atresia. So it's like they're saying like the bowel becomes discontinuous, and sometimes this is referred to as the triple bubble, which is also hilarious. So the first bubble is going to be the stomach, the dilated stomach. The second one is going to be the duodenum, like the dilated duodenum, and then the third one is going to be either the dilated jejunum or the dilated ileum. And again, the reason it looks discontinuous is there are sphincters here kind of controlling, so parts of it can get dilated, kind of like the last one, but now we added on like a segment. That's why it's triple bubble. Okay, so next is pyloric stenosis. This is also probably another one that I would mark as like high yield, like very high yield to know, because this is the most common cause of gastric outlet obstruction in infants. So this happens in every 600 infants that are born, one of them will have pyloric stenosis. And basically it is what it sounds like. The pylorus becomes stenotic. So remember stenosis from cardio. We kind of talked about it with the esophagus. The esophagus can get stenosis. It's just like a narrowing towards the end. So pyloric stenosis is, remember the pyloric antrum. So remember like with anatomy, I was like, oh yeah, this is like the antrum of the stomach, and then we have the pyloric sphincter. But remember, the whole thing is technically the pylorus, and then they differentiate it like antrum, sphincter, blah, blah, blah. So that last part of the stomach right before where the pyloric sphincter is becomes stenotic, and it's because there's thickened muscle there. So it's almost kind of like a hokum type of situation where there's thickened like interventricular septum. Kind of the same thing here. This thickened muscle right where the pyloric antrum is obstructing food coming in. Okay, so this is, first of all, the most common. Second of all, this really commonly happens in firstborn males. And I put males in here and highlighted it because I've never seen a question where a female, like at least vignette, where a female baby has had pyloric stenosis. So again, I always tell you guys, like with like ages and sex of the person in the vignette, I'm always like, I don't love using that because like PBL, like not even PBL, just in life, they don't have to abide by that. Pyloric stenosis, they tend to abide by it. It's really only in males. Don't know why. It's not like it's X-linked. It's nothing like that. It just happens more in males for some reason, the firstborn males. But what kind of gives it away is you're palpating the baby's stomach and you feel an olive-shaped mass. So literally an olive that you eat, again, ruining foods. So you feel an olive-shaped mass in the epigastric region. Because again, this is the stomach. Remember, the stomach is up in the epigastric region. So you feel it. What you're feeling with that olive-shaped mass is going to be this thickened muscle. You're basically feeling this when you're palpating. Sometimes vignettes won't mention this because they know it's a dead giveaway for pyloric stenosis, but if they do, it's pyloric stenosis. Another thing that you can see is visible peristaltic waves. It's kind of like the stomach is like trying its hardest to like get this food through here. It's like, we need to get food through here. So it is like not audibly, like visibly peristalsising. So you're looking at the baby and you see the stomach just like going like this, and it's trying to get that food through this like stenotic pylorus down here. This is non-bilious vomiting. So again, duodenal atresia is going to be bilious vomiting. Tracheoesophageal fistula is going to be non-bilious vomiting. This is also non-bilious vomiting. That makes sense. We are not near the second part of the duodenum yet. We're still in the stomach technically, or like that first part of the duodenum. We're in that region. But what's really interesting, and this is why timeline is key, and you can use this, especially this versus this one, to kind of help you differentiate between all of these types, is the timeline. When does the baby start vomiting? When does the baby start having these symptoms? Duodenal atresia happens as soon as the baby is born because food can't get through there. It's like food cannot get through the duodenum. There's just nothing there. There's no place for it to go. There's no canal. Here, it's like, yes, there's thickened muscle, but it's something that actually gets worse as it progresses. So maybe the thickened muscle, it's like a little thick at the beginning, but then over time it gets thicker and thicker, and then it gets more and more stenotic, more and more stenotic, more and more stenotic, more and more stenotic, and then boom, you get that full obstruction. So look for vignettes 2 to 6 weeks. Okay, it's just like oh no, you guys are first years. I was gonna say we did this with nephrotic syndromes. Remember, guys? No, that's second year renal. But timing is key for that, and it's key for this. Okay, so if it's happening as soon as the baby is born, you're like, this sounds just like pyloric stenosis. It's a firstborn male. There's vomiting of some sort. They don't tell me bilious versus non-bilious. But then they say this is the first feed, or this is the first time, like the first the first day of life. Nope, rule it out. Cannot be pyloric stenosis, okay? Needs to be anywhere from 2 weeks like on for symptoms to start. And the only way to really treat this is what's known as a pyloromyotomy, where you just go in there and you literally remove the pylorus. You just remove it. Okay? Okay, so then pancreatic development, remember that the pancreas is foregut derived, but there are some some ventral and dorsal mesoderm that mesentery that gives rise to these buds. So what I meant by that earlier and what I'm going to talk about now is see how the pancreas there's a dorsal bud and a ventral bud. The ventral bud kind of like swings around and joins the dorsal bud as it's developing. So you can kind of see, I actually really like this first aid picture because they went through like the slow motion of it moving. I'm like, oh, that's kind of tricky. That's cool of them to do. So it's over here. It literally looks like a leaf on like a plant. And then it swings around and it swings behind the duodenum. See that this is like the stomach, the pylorus. This would be like the second part of the duodenum. Well, it would be after the second part because this is where the ampulla of Vater is, because that's where the common bile duct and the main pancreatic duct enter the duodenum. But regardless, during development, this ventral bud is going to swing behind it and then join the rest of the pancreas, the dorsal bud. Sometimes I'll ask you anatomy. Sometimes they'll be like, oh, like what does the dorsal bud contribute to? Like what part of the pancreas does the dorsal bud contribute to? I should have probably had like anatomy, like this type of anatomy, but it's fine in the last one. But the dorsal bud is everything in blue is what it contributes to. So it's going to contribute to what's known as the uncinate process of the pancreas, which is just like if you look at a pancreas, there's like, it almost looks like there's this, oh my God, that's so bad. Wow. That looks like a high heel. All right. Well, this bottom part of the pancreas is called the uncinate process. So that comes completely from the ventral bud is the uncinate process. And then you can notice here that the ventral bud also completely contributes to the main pancreatic duct. Well, not the main one, but yeah, the main pancreatic duct. Okay. And then the dorsal bud, which is already there's no swinging of the dorsal bud, that contributes to the tail, the neck, and then the accessory duct of the pancreas. And then the head, which is kind of like this area, you can see is both dorsal and ventral bud. So sometimes they will ask like just a quick multiple choice, like what part of the pancreas came from the ventral bud or something like that. So I would have that in mind. All right, so with this in mind, you can already imagine what the pathology state's going to be here. It's going to be what happens if this ventral bud rotates the wrong way or it swings it swings in front of the duodenum. And that's kind of like exactly what happened. So this is called annular pancreas. So annular pancreas is where this ventral bud here, so this ventral bud, instead of swinging behind the duodenum like it should, it swings in front of the duodenum for some odd reason. And when it connects to the pancreas, now imagine the pancreas is formed like this, it's going to completely just crush that part of the duodenum. And that's right around where the second part, it's a little bit after, remember on here, it's like a little bit after the second part of the duodenum, because the second part of the duodenum, I would say, is right here, because that's where ampulla of Vater is. It would be like right at that level, be like right here. So it swings around, and now you have what's known as an annular pancreas. And even on x-ray, it really looks like there's like this ring. Like this ring is around basically where the second part of the duodenum is. Okay, so it completely circularizes around the duodenum. That's called annular pancreas. And since we're right at the level of the duodenum, like when this kind of rotates forward, we're basically taking out where the ampulla of Vater is. It's almost as if it's like a complete blockage of, pancreatic juices, of this common bile duct. So these things can't get in there. So you actually see non-bilious vomiting. But it's just because of the location, it's right there at that level. So it's not even allowing for like bile to enter. So you see non-bilious vomiting with this one. The other pathology state you can see with pancreas is called pancreas divisum. Again, kind of exactly how it sounds. It's like the pancreas almost like like the ducts of the pancreas are like not connected. They're like divided in two. So Sometimes they ask time-wise. That's why I put like weeks, like what week does this happen at? So dorsal and ventral bud, this happens like at week 8. If they don't fuse, so let's say there's like they do swing around, like it does swing around, but they don't fuse now after it swings around. Oops. So it's well, this is the wrong let's go to this one. So it swings, but then when it swings around, it just kind of like these ducts just don't fuse. They just kind of are like, all right, here's this part of the pancreas, here's this part of the pancreas. And it's almost like they're two separate entities. It's like the pancreas is divided. That's like your pancreas divisum. This is common. Usually it doesn't matter too much. Like it honestly is kind of fine. It's just like the body kind of adapts, and it like you might have like some issues, like you might have similar symptoms to like pancreatitis, because now it's like there's really no way to get like the pancreatic enzymes into the small intestine. But sometimes too, like you might not have a complete divisum. Like sometimes it's just like a little portion of it. Sometimes it's complete, like this one. This one would probably be a little bit more severe than like not as divided between the two. So you may see symptoms, you may see no symptoms, but if they're talking about like the ducts are not fusing, that's pancreas divisum. Okay. Hirschsprungs. So Hirschsprungs is my favorite. It's definitely the most high yield. And the reason it is because they ask so many things about Hirschsprungs. They can ask about genetics, they can ask about the nervous system, they can ask about embryology, they can ask about path. Like they love Hirschsprungs. When you guys do endo, you'll learn about a certain type of disorder that so it's called like a MEN syndrome, MEN. You'll learn about it in endo. A lot of the times these MEN syndromes have what's known as RET mutations, RET. Hirschsprung's is also a RET mutation. So it's kind of like, there's a lot that they can ask about Hirschsprung's. And what they call this is congenital megacolon. So congenital megacolon, you can already imagine the colon is going to be very large. So what happens in Hirschsprung's is basically the ganglion cells and like the cells that come from that make the enteric nervous system in the distal colon. So this is like, descending colon, like sigmoid, like that type of, it's different every time, but it's going to be like the bottom part. It's going to be like from like the bottom descending colon, rectum, like sigmoid colon, rectum, that type. Like that is what is affected in Hirschsprung's. And specifically, you don't get migration of either Auerbach's plexus or Meissner's plexus. So there's just no Auerbach, no Meissner's. Okay. And the underlying cause of this is there's not proper neural crust cell migration. So remember, neural crust cells come from ectoderm. Just tying that in there. Remember embryo. But because we're not getting these neural crust cells migrating to basically it's only to this last part of the colon, you don't have enteric nervous system here. So just imagine like not having Auerbach and Meissner's plexus in the bottom part of the colon. It's not good. You can't squeeze, like the colon can't squeeze food to help you get rid of it. So it just kind of sits there, and then it gets big, 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 and there's your megacolon. This is also associated with Down syndrome. There's lots of things that are associated with Down syndrome. But sometimes I'll ask about the specific gene mutation. It's RET, so RET. This is like the actual gene mutation that causes this condition. Like I said, RET is not just common for Hirschsprung's. You see RET mutations in these MEN syndromes you guys will do in endo. But how would you see this in a vignette? They're not going to say, oh, I see congenital megacolon. They're going to say things like, oh, the patient has bilious vomiting. So that's how backed up it is. It goes from all the way from the colon, all the way back through the small intestine, all the way back up for vomiting. It's obviously bilious because this is clearly after the second part of the small intestine. Abdominal distension, the colon gets super big. Of course, there's going to be abdominal distension. And then failure to pass meconium within 48 hours. So this is almost like diagnostic of Hirschsprung's. So what they do when a baby is born, one of the first things that a doctor does is he does this to check for Hirschsprung's, basically. He will stick a thumb up the anus into the rectal vault. So it's called the rectal vault. So you're trying to go up to where the rectum is and see if there's what's known as meconium there. Meconium is kind of like the first stool. So the very first stool that a baby has is called meconium. It should be there. It should be in the rectal vault. Okay. So sometimes they'll say, like, how they'll word it in a vignette is like, digital rectal, like the doctor performed a digital rectal exam and there was an empty rectal vault, or there was no stool present in the rectum. These are all kind of buzzwords for Hirschsprung's, okay? It's like an empty rectal vault. The reason why is because you can't get the stool that's here into the rectum because there's no nervous system. There's nothing to cause that contraction of the colon. So it's stuck, all the stool's stuck up here, and that's what, again, is causing the colon to get really, really big. But this is all empty. I'll show you a picture of it. But what's really interesting too is like the normal portion of the colon, which is proximal, so above that aganglionic segment, because ganglionic, like these are ganglions, right? These are nervous cell ganglions. These are ganglion cells. So this is all going to be aganglionic because there's no nervous cells here. But then there's like this demarcation where all of a sudden it's like there are ganglionic cells because this is all normal colon. It's just the distal colon. It's super weird. And again, it's because of those neural crust cells don't migrate all the way. And then, so sometimes they call that the transition zone from like the aganglionic segment to the ganglionic segment. And they know exactly they're like, oh, right here, we have ganglion cells. And that's important to know for like treatment because you want to remove that aganglionic segment. But we'll talk about that. Okay. So this is, again, Hirschsprung's disease. So for example, here's your normal colon. All these yellow, this is all the ganglion cells. So these are all the cells that kind of make up the submucosal and the myenteric plexuses, Auerbach and Meissner's plexuses. But then all of a sudden, like this part, for example, for whatever reason, had no migration of those neural crust cells there. So they don't have Meissner's plexus. They don't have Auerbach's plexus. Auerbach's plexus is the one that actually stimulates the contraction. That's the muscular one. So there's like stool can't get there. So they kind of like look, and then they go, boom, here is the transition zone between aganglionic and ganglionic. And usually that's the area that's going to be super, super enlarged. Because again, it's just all that stool that's just sitting there. And the longer you wait, the more backed up it can just back up. It can just keep going. Yeah. Here's another picture. So that's why they call it like megacolon, because the colon gets very enlarged, especially like this isn't a child, so it's going to seem even more enlarged. But it's always going to be that distal segment. So it's always going to be on the left side of the patient because it's the distal colon. Okay. I do have Meckel's diverticulum in here. So remember Meckel's diverticulum, this is what's the most common cause of intussusception in children. So this is like what's this causing like that lead point for that telescoping of the bowel. All right, so this is a really weird thing. I had Meckel's diverticulum on step, and I even was like, I knew it was Meckel's diverticulum, and I was like, even taking step, I'm like, this is such a wild thing that happens. So I think the reason they like this is because it doesn't sound like anything that's normal. It sounds like a mixture of a bunch of different types of pathologies, and it's this one thing. So some definitions, a diverticulum is an outpouch. So, I've briefly mentioned diverticulitis, which is going to be like the colon has these little outpouches, like just kind of like outpouching out of the colon. That's what a diverticulum is. So Meckel's diverticulum is a diverticulum. So it's going to be an outpouch of a certain region. We're going to be over by the cecum, which I'll show you a picture. But it's going to be somewhere in that area, and it's just like you just have this one outpouch. That's Meckel's diverticulum. Usually, so the reason of this is, so sometimes they'll tie an embryo with this and be like, well, what causes Meckel's diverticulum? And the vitelline duct, which I will show you, the vitelline duct doesn't completely obliterate. It's kind of like allantois. Like if the allantois doesn't completely obliterate, you can have like urine leaving the belly button. This is kind of like a similar thing. So it's kind of like the vitelline duct doesn't completely obliterate, and now we have this outpouch that kind of remains. It's often asymptomatic, which is good, but the ones I ask you about is this fact, and this is what makes it absolutely wild. So this little outpouch, which is in the colon, like it has nothing to do with like the stomach or the pancreas. It can contain ectopic gastric tissue or ectopic pancreatic tissue. And remember, ectopic, we've talked about ectopic before. It just means something is being produced not where it should, like not outside of where it normally is produced. So for example, gastric tissue produces gastric tissue should be in the stomach. If you have gastric tissue in the colon, that is ectopic gastric tissue. Like it shouldn't be there, but it's there. Same thing with pancreatic tissue. Like ectopic the pancreatic tissue should be in the pancreas, not in the colon. So, but since so imagine just like we have this little out pouch in the colon. So I'm gonna draw it. So we have this little out pouch, and then I just realized I could do this the other day. I could change colors of my pen. Remember, I'm always like, oh, I wish I had a different color pen. Well, I actually can. All right. So let's say this is gastric tissue. What does gastric tissue secrete? Hydrochloric acid, HCl. Let's say there's pancreatic tissue here as well. So there's ectopic pancreatic tissue. What does pancreatic tissue produce? Like the enzymes, amylase and lipase. I'll just say enzymes, ENZ. So now we're in the colon, and we have hydrochloric acid being produced and pancreatic enzymes. So you can see why people absolutely love this type of pathology state, because they can describe to you pancreatitis, or they can describe to you like basically having an ulcer, and then ask like, what's the most common cause of this telescoping of the bowel? And you're like, wait, what? Like, you're just like, aren't we talking about pancreatitis? Like the entire vignette, I'm like, I think this is pancreatitis. And then it ends up being, oh, it's not pancreatitis. It's just this person has Meckel's diverticulum. They just have pancreatic tissue in the colon. And you're like, oh, okay, sure. But since we are kind of near where that ileocecal valve is, because that's like, again, the most common location of Meckel's diverticulum, it's going to be in like that area, like the first part of the cecum, it can mimic appendicitis symptoms. So not only can this sound like, an ulcer, not only can it sound like acute pancreatitis, it can also sound like appendicitis with this patient. And you're like, I have no idea what's going on with this patient. And it's just, it only kind of mimics appendicitis because it's near the appendix. So you're like, oh, I have right lower quadrant pain. And everyone's like, oh my God, in a child, oh my God, appendicitis for sure. So just keep that in mind. This is a really weird one. They love Meckel's diverticulum. I'm not kidding. Just keep it in mind if it's like they're asking about like pancreatitis, like it just sounds like wild. Just be like, could this be Meckel's diverticulum? Like, this just sounds a little too chaotic for me. Anything you read that sounds chaotic, ask yourself if it's Meckel's diverticulum. And then people tend to say like rule of twos. I don't think this is very helpful, but I put it in here anyway. So rule of twos is like, this happens in 2% of patients. It happens 2 feet before the ileocecal valve, which sounds pretty far, honestly, but it's near the ileocecal valve. It's 2 inches long, so that's like how long this little out pouch is. It's usually like 2 inches. It's 2 times as likely in males, and it presents within the first 2 years of life. It's always, not all, but it's like always with the little asterisk, because I never say always, gonna be in children. All right. So vitelline duct abnormalities. So this is again, I didn't really go into like the vitelline duct. You will actually go into the vitelline duct again in repro. Like, you'll do a lot of embryo stuff in repro. But basically, like, you can see part of the ileum, like before where the cecum is, like basically, so I was saying colon, it's in the small intestine, my apologies. So it's in the ileum, but it's going to be like right before the cecum. It's like the part of the ileum that's closest. That's why it's like you feel that right lower quadrant pain. And then boom, you have a little outpouching. But what makes it Meckel's diverticulum is that weird tissue in here, gastric tissue, pancreatic tissue. Like, you have all these weird ectopic tissue here that you're like, that's so odd. But that's Meckel's diverticulum. You can also have like a vitelline duct fistula. And remember, fistula is just an abnormal connection. So you can have a connection from the ileum into the umbilicus, which is weird. You can get a cyst, and you can also have fibrous bands. So it's kind of very similar to the one we talked about in renal, with like urine leaving the belly button. You can have food and digested food leaving the belly button, which is kind of weird. Okay, but Meckel's diverticulum, again, it's not just any diverticulum in the ileum. It is that diverticulum that has that weird tissue attached to it. All right. And then, oh yeah, I did forget I had this in here. So so we had talked about the allantois in renal. I remember I talked about if you have a persistent allantois, or the allantois did not obliterate, that connects like to the belly button. So you can technically have urine leaving the belly button, right? So you can have urine leaving the belly button. You have this persistent allantois, and that is just a pathology state that happens with renal. But with the vitelline duct abnormality, so if you have a persistent vitelline duct, it's kind of like this like fistula. It's kind of like a fistula almost, but you have like the vitelline duct is connecting the midgut to the umbilicus, you can actually have meconium discharge from the belly button. So imagine a baby's born and there's poop just coming out of their belly button. That is a persistent vitelline duct, okay? It's kind of the same thing though if you have a baby's born and there's pee coming from the belly button, that's a persistent allantois, okay? All right. All right. Hernias. So I am going to talk about inguinal hernias, and like I said, feel free to not like listen to them or just like save them for repro, or I mean, honestly, there might be hernia questions on your exam. So it's still technically GI, but you will do it in repro, I promise. So if you're just like, I don't feel like doing inguinal hernias, power to, yeah, that's totally fine. But they will be covered here. So but these are the two I think you should at least know for GI, okay? So there's two hernias that you should know for GI. They're called hiatal hernias, and they're only called hiatal hernias because they both basically occur where the esophageal hiatus is. There's two types of hiatal, sliding or paraesophageal, okay? So you can have a sliding hiatal, paraesophageal, and we'll talk about that. Sliding hiatal hernias, these usually occur in like older adults, so like middle-aged, 50, 60 years old. It's another one of those ones that's just like people get old, things happen type of thing. This is where the cardia of the stomach will herniate up into the esophagus. So remember, we have the esophagus, it connects into the stomach. Oh my gosh, I can't draw. Well, I'm going to draw it like that because remember, the cardia is the first part. So as soon as food comes in from the esophagus, we have the cardia, the fundus is here, the body, and then the antrum, the pyloric antrum, whatever is down here. So with the sliding hiatal hernia, the cardia portion of the stomach herniates up through the esophagus, but it's at the level of basically where the diaphragm, like where the esophagus passes through the diaphragm. So that's the level of it. This is also the level of where the heart is kind of like sitting. The heart's kind of here. Again, that's why they call it the cardia. Remember we talked about that with anatomy. The heart is here. So a lot of the times this is people that feel like they have heartburn, or they feel like they're like, oh my God, I'm having a heart attack. My chest hurts. It's really just reflux, basically. But it might be it might just be like normal reflux, which is just people, you ate something spicy and then you have reflux. This is like an actual like herniation of part of the stomach up into the esophagus. Now you have, stomach juices up in the esophagus, which the esophagus is not used to that environment. So the cells there are not equipped to handle that, and that causes like the heartburn and the GERD and all that stuff. So my question here is the hernia of the cardia of the stomach into the thorax. So it goes up into like where the thoracic cavity is through the esophageal hiatus of the diaphragm. What level is that? So remember, I ate 10 vegan eggs at almost 12. That comes back. So remember, I ate 10 vegan eggs, T10. So this is at the level of T10. Sometimes they'll ask that. Anatomy, they love anatomy. But remember that the vagus nerve also comes in through T10 because I ate 10 vegan eggs. You're eating vegan eggs at T10. So remember, the vagus chunks pass through this level as well. So what can happen is this herniation, you can take out the vagus nerve. And remember, the vagus nerve is the nerve that does everything in the GI tract. I mean, this is like your rest and digest nerve. So you won't get any stomach like acid production at all. It's like nothing's telling the stomach to make like release hydrochloric acid, gastric acid, those gastric juices. Like nothing's telling it to do that because you take out the vagus nerve. So what they say is you can have hyposecretion of gastric juices. And this is kind of like, remember like the vagus nerve in every other part of the body is like, that's like your rest. So it usually slows things down. In the GI tract, the vagus nerve speeds everything up. And so now it's like you take out the vagus nerve, you don't get as much production as like your GI like secretions and whatnot. Okay. So that's a sliding hiatal hernia, and they call it sliding because like this part of the hernia, this part of the stomach just like slides up through the esophagus. Paraesophageal it doesn't slide up, it's like slides to the side of it. So I'm not going to draw it, I'll just show you a picture. So over here, this is paraesophageal. So like the part of the stomach, it doesn't directly slide up through the esophagus, it goes right next to the esophagus. But luckily they told you that in the name. Paraesophageal. Para means right next to. So right next to the esophagus, we have this hiatal hernia. So it does go through here. And usually what they'll say to help you like identify this one is they'll say like, oh, I'm listening to the patient's lungs, and all of a sudden I hear bowel sounds in the lung fields. And you're like, what? Like, why do I hear bowel sounds like up in the lungs? So that's usually a paraesophageal hiatal hernia. And this is from first aid, just some other things that they can mention to help you like identify these. So sliding hiatal, remember it's going to be the cardia, it herniates up. Now we're having literal production of gastric juices in the esophagus. So that can lead to GERD, it can lead to heartburn, chest pain, like all that stuff. Sometimes what they'll say is like you did an x-ray and there's an hourglass appearance. Because again, it slides directly where that hiatus is. That's why it gets the name hiatal hernia. It's right where that esophageal hiatus is. So it's like the stomach is the bottom part of the hourglass, and then the herniation up through is the top part of the hourglass. And then paraesophageal, it like doesn't go directly through the esophagus, it goes next to the esophagus, and then you get those bowel sounds in the lung fields. All right, I bid you adieu to whoever's not doing inguinal hernias, but you will at least have it for repro because you will need to know this in repro. And basically all inguinal hernias is the bowels, so parts of the bowel are now going to herniate in the inguinal region, okay? So there is going to be a little bit, well, not really like anatomy, but there is going to be a little bit of like reproductive structures I'm going to kind of point out, but we'll do repro anatomy when you get to it next block. But again, I was asked to tutor this for people in the past during GI block, and I almost wonder if it's because like they're block people, because again, even here, I'm like, these are the ones you'll cover again in repro. Like I left this in here from the last time I tutored this. So it's like I told people like you'll probably cover this in repro, but it's almost like it makes me wonder if their facilitators were telling them like, hey, maybe no inguinal hernias or, you know, something like that. All right, anyway, so this is a little chaotic. So we have to kind of talk about anatomy of the inguinal area to kind of go into this, but you're going to see this word called aponeurosis. So aponeurosis, basically an aponeurosis is connective tissue that connects a muscle to another muscle. So especially in the abdominal muscles, all of the abdominal muscles are basically all have aponeuroses because it's a muscle. There's 3 types of abdominal muscles, and each are connected with these aponeuroses to each other. Okay, so these are the 3 types. So you have your external oblique, your internal oblique, and then your transversus abdominis. And all of these are going to be in like a layer from outside to inside. So external oblique, this is like when you go to the gym and you like literally exercise oblique muscles. It's going to be the ones on the outermost area. Then you have your internal obliques, which are a little bit more inside of those. And then you have your transversus abdominis, which are going to be the innermost layer of the abdominal cavity. Then this is now, so that's literally the abdominal cavity. So that's the abdomen. But then if you go all the way down to where the spermatic cord is, so this is basically in a male, so this is the testicle. So this, it doesn't keep these names in external oblique, internal oblique, transversus abdominis. It now switches to external spermatic fascia because it's just layering on this where the spermatic cord is, which is what basically is bringing down the testicles. That's your spermatic cord. The external spermatic fascia is like that external oblique. The cremasteric fascia, that would be your internal oblique. And then the internal spermatic fascia, I know, I wish it kind of kept it the same, but it didn't. Your internal spermatic fascia, that would be what the transversus abdominis was. And that's why I like this picture, even though it's kind of blurry. If you follow like external oblique down, it turns into the external spermatic fascia. You follow the internal oblique down, it turns into the cremasteric fascia. And you follow the transversus abdominis down, it turns into the internal spermatic fascia. Okay? So these are just like so this is the fascia surrounding the spermatic cord, but it's basically just these abdominal layers that got renamed. Okay? And then another thing I want to point out before we go into these herniations are the rings. So you have different types of what's known as inguinal rings. And this is pretty much where the spermatic cord starts to enter, where all like these arteries, veins, whatever, kind of go into now the spermatic cord. It's kind of like a little canal. So we have this deep ring here, and then we have this superficial inguinal ring here. And through it is where the spermatic cord goes down. Okay? take my word for it. I'll show you a bunch of different pictures. But first I want to talk about these guys, these abdominal muscles, and kind of show you it's literally the abdominal muscle. So again, external oblique, this is the outermost. You peel it back, you have your internal oblique, you peel that back, you have the transversus abdominis. And remember, it just turns into the different layers of the spermatic cord when you get there. Okay, next I want to talk about these guys. So to show you a better picture of these two rings, this is pretty much what makes the inguinal canal. Like I said, it's a canal. The deep ring is going to be the ring closer to the ASIS. And then the superficial ring is going to be the ring closest to the pubic tubercle. So the ASIS, I don't think you guys did ASIS. Actually, I don't know if you did ASIS stuff yet in OMM. If you haven't, you will. But the ASIS is basically like your hip bone. Like if you put your hands on your hips and feel like at the front, if you were to feel your hips on the front of your body, that's your ASIS. And then the pubic tubercle is the pubic bone. There's this canal that kind of sits there. And in men, this is where the spermatic cord goes through. But how they kind of say like where you can find the opening to this inguinal canal is halfway between the ASIS and the pubic bone, basically. That's the deep ring, and then the superficial ring is like just closer to the pubic tubercle. And you have this ligament, it's called the inguinal ligament, and the canal kind of sits like on this ligament. I don't know if it's in this picture. I definitely have another picture to show you like the ligament, but I think it's in this guy. So see, like, here's your ASIS here, here's your pubic tubercle here, this is your ligament. This is the ligament I was talking about. So if you imagine now fascia and all the other layers of skin, whatever, that's where the deep inguinal ring would be, and then the superficial inguinal ring would be. It's like sitting on the ligament. Okay. Okay, so then this is just another view of, okay, I ended here, sorry. So that's what this inguinal ligament is. But then to finally end it off with the fascia surrounding the spermatic cord and testes is here's your spermatic cord. Again, this would probably be the superficial inguinal ring because it enters through that canal, the inguinal canal, and then it kind of leaves, and then it goes into like basically the scrotal sac, and that's where all these layers are. So again, surrounding it entirely it's not labeled on here, but it would be like the external spermatic fascia, which again came from the external oblique muscle, cremasteric fascia, which came from the internal oblique muscle, and then internal spermatic fascia from the transversalis fascia, that transversus abdominis muscle. And then it comes down like this. And yeah, so just kind of wanted to point out those layers. Here's another view of the inguinal canal. So again, to kind of like help you orient yourself, this is going to be the patient's right side. So this would be like the right ASIS would be over here. And then this would be like where the pubic tubercle would be like over here. So we have the deep ring here, then the spermatic cord would kind of go through here, and then you have the superficial ring here. And then this would continue down into like the scrotum and that would like go to the testicles. Okay. Another thing I want to point out, another structure I want to point out. So if we do this again kind of thing, they kind of call this like the transversus abdominis muscle and whatnot. They just kept it the same, because again, it's like they're the same thing. It's just like it's annoying when they switch back and forth between the abdominal muscles and then the cremus, like the different types of fascia, but they're the same thing. So you can find those 3 layers of fascia. But what I wanted to really point out with this picture are these inferior epigastric vessels. Okay, so inferior epigastric vessels are going to be a landmark for herniations, for these inguinal herniations. And if you look at any of these pictures, they're always going to be basically right at the entrance, like right where the entrance of the deep ring. So right at the entrance of the inguinal canal are going to have these inferior epigastric vessels. So here they are again. Here's your, So these are your inferior epigastric vessels here. Here they are again here. It's always an artery and a vein. And then here they are again here. And this, for context, would be on the left side of the patient. Here would be the ASIS up here, and then the pubic tubercle over here. So you can imagine it's going down like that. And then here are the inferior epigastric vessels. Okay, so this is just like if you just can't remember, there's just so much to remember, right? If you like can't remember that, for example, the transversus abdominis gives rise to the internal spermatic fascia. Like if you can't remember from the abdominal cavity to the to the fascia surrounding the spermatic cord. The mnemonic people use is ice tie. So ice tie, ice is in reference to the one around the spermatic cord, and then tie is in reference to those abdominal muscles. So it's basically saying like the internal spermatic fascia comes from the transversus abdominis muscle, cremasteric fascia comes from the internal oblique muscle, and then external spermatic fascia comes from the external oblique muscle. But again, it's just like I said, if you kind of follow it down, it just kind of turns into the external, like external turns into external. It just gets a little tricky with the internal and cremasteric fascia, because internal oblique is not the most internal in this set, but the internal fascia is the most internal with this set. Okay. So I really like this picture because I want to show you this weak area. This is a site of one of the herniations. So for context, this is probably on the right side. So this would be like the right ASAS would be up here. The pubic tubercle would probably be here. They just didn't draw it in. And then here is your deep inguinal ring. It's the start of the inguinal canal. Here's your superficial. Where is it? Probably like right here. I know it's pointing down here, but I'm like, nah, you need a ring. So it's probably like right here. That's like your superficial inguinal ring. And then this would be the inguinal canal. Okay. Landmark, inferior epigastric vessels, right here. They're always going to be right next to the opening of it. And then it lists 1, 2, 3 based on either the abdominal muscle fascia name or the spermatic cord fascia name. So they're again getting used to seeing both of them because they're like basically the same thing. And then really want to point out this weak area right here. It's like this weak area. There's no muscles here. There's really no connective tissue. This is going to be a site of specific types of hernias, like a specific type of hernia we're going to talk about. It's like the weak area of the inguinal area. And this is like where one of the hernias are. So I just wanted to point that out before we go into the hernia types. Okay, so we're going to talk about abdominal hernias. So the reason it kind of like straddles the line between like GI and repro is because it is technically the abdominal contents. The GI organs are going to be extruding out into the inguinal region. There are 3 types, indirect, direct, and femoral. But the common question they like to ask in terms of anatomy with like all this stuff is what's the very first like layer or structure that's passed by any of these hernias? And it's going to be that transversalis fascia, because the transversalis fascia is going to be the one closest to where the abdominal organs are. I like this picture the most because again, the transversalis fascia, it's like this green, it's the innermost layer. So imagine having like an abdominal organ, like a small intestine, kind of come through and herniate through. It's going to basically pass through this before it passes through cremasteric fascia, before it passes through internal spermatic fascia, any of those oblique muscles. Like it's always going to be the transversalis fascia is always going to be that first layer that's being crossed by any herniation. Okay, so that's like a common anatomy question. Okay, so indirect inguinal, this is the most common type, and I want to put it in your guys' heads now that this, while it tends to be more common in males, so it's 20 times more common in men than women, it's still the most common in women, okay? And I mention it because we are going to talk about another type of hernia that is almost happening exclusively in women. But I think when people see that it's a hernia question in a vignette, and then they see like, oh, this is a woman, it must be that other type of hernia we're going to talk about, when in reality, indirect inguinals are still the most common type even in women. So I just don't want you to like reflexively pick the one that only happens in women when this one is like just as like it's more common in women, okay, than the other one. But overall, this is way more common in men. Usually it's going to be like a 20-year-old, 23-year-old, like a younger male is going to get an indirect inguinal hernia. My brother had one of these. He played college football. He had an indirect inguinal hernia. And I'm like, that's the exact like person that would have an indirect inguinal hernia, as like a college athlete that's lifting weights all the time, like just tons of increased intraperitoneal pressure, just pushes like the abdominal contents like just elsewhere. But the reason too is indirect inguinal hernias can also be congenital. So you might not see them in like 24-year-old men. You can also see them in infants, like just newborn infants. They're not weightlifting, but there's a congenital cause for it. So this indirect inguinals are going to pass through the deep inguinal ring. So remember we have the deep inguinal ring, and then we have the inguinal canal, and then we have the superficial inguinal ring down here. And then the inferior epigastric vessels are usually right here. And this would be on the right side. So we have like the ASIS on the right side here, and then the pubic tubercle. So it's like this was like the right hip going in. So this would be like where the abdominal contents would go through the deep ring. So they'll pass through the deep inguinal ring. And when they enter, they're entering lateral to these inferior epigastric vessels, right? Because remember, this is on the right side. So this is like the hip. This is the outside of the patient's body. This is midline. This is where the pubic tubercle is. This is like the midline. So here are the inferior epigastrics. So like artery, vein, the herniation is lateral to those because this is like away from the midline. And they'll use this a lot to help you identify like what type of hernia it is using these inferior epigastrics as like a landmark. Okay, so they're going to herniate through the deep inguinal ring. They're going to go through the inguinal canal, and they're going to go through the superficial inguinal ring. And then in some instances, they can descend into the scrotum. Wild to me. This sounds so painful. I'm like, oh my God. I'm like, how did you get this? It sounds so painful. But it goes through all of them into the scrotum. So you have intestine in the scrotum in some instances. This is more common on the right. So remember we talked about varicoceles, like very briefly in renal. And those are more common on the left. This is more common on the right. And the reason why is because of embryo. And I'll go into like the embryo, but there's a structure you should be aware of. It's called the processus vaginalis. And the processus vaginalis is what allows the peritoneal cavity to talk to like the developing spermatic cord and the developing scrotum and testes and all that stuff. It kind of allows, because again, remember, like when you're in utero, everything's kind of connected. We're just a series of tubes when we're in utero. So it's kind of like it allows the peritoneal cavity to talk to like the scrotum and the testes and whatnot. So if that does not obliterate after development, you basically have this opening from the peritoneal cavity into the scrotum, and that can fill up with water, and then you can see something called a hydrocele, which I'll show you on the next slide. But the right processus vaginalis usually obliterates after the left processus vaginalis. And once that obliterates, that's kind of what allows the testicles to descend. That will be repro. You guys will cover this in repro. I just really wanted to give you more of a baseline of these types of hernias. But we're going to look at some pictures. So yes, these are going to be some bumps and lumps everywhere. But this is pretty much what we were talking about. The intestine's going to go through the deep inguinal ring, go through the superficial inguinal ring, and actually descend along the pathway of testicular descent. So it kind of goes along with like how the testicles would descend. Because and you guys will cover this in repro, but like during development, the testicles actually start up in the stomach and then they descend down. So literally they will descend downwards. So this kind of, sometimes they'll say like, oh, this herniation follows the pathway of testicular descent because it just follows that spermatic cord, which is pretty much what helps it descend. But notice here it goes through both the deep and superficial inguinal rings. It goes through both of them. It looks like a lump. Depending, again, on how far it descends down, it can go really far down. It can be a little higher up, like in this image. But basically, when the processus vaginalis does not close, you have fluid from so this is the processus vaginalis. It remains patent, or it remains open. You can have peritoneal fluid, which is just like water, that can leak into the scrotum. So it can literally leak into the scrotum. This is called a hydrocele. Hydro meaning water. Seal meaning like, it's not like a true herniation, but it's kind of like a little herniation of water because it's water's where it shouldn't be, right? It should be in the peritoneal cavity, and now it's in the scrotum. So that's kind of like what the hydrocele is, and that's what processus vaginalis. It should form what's known as the tunica vaginalis, and if it remains patent, you can have a hydrocele. Okay, cool. This next one is a direct inguinal hernia. This is a lot less common than indirect. This actually mostly happens in males, but like older men. This is like one that would be like an older man that's trying to like lift up something heavy, and then they're like, oh, something happened. That's like a direct inguinal hernia. This is where the abdominal contents would protrude through that weak area. So remember I showed you, I was like, oh, like this weak area, direct inguinal hernias, the herniation goes through that weak area. This is going to be medial to those inferior epigastric vessels. So if I go back to my little drawing, Oh God. So here is my indirect. It goes through the deep inguinal ring, the superficial inguinal ring. Now let's say we have a herniation medial to the inferior epigastric vessels. That would be over here. So that's where that weak area is, and the intestinal contents would protrude through here. Okay. So medial to the inferior epigastrics. It's called a direct hernia because it goes through it goes directly through what's known as Hasselbalch's triangle. And when it goes through Hasselbalch's triangle, it goes through that superficial ring. And again, I'll show you a picture. It's good to know the contents of Hasselbalch's triangle. Sometimes they call this the inguinal triangle. It's like the same thing. They know Hasselbalch's triangle is like kind of like a buzzword. So sometimes they'll say like inguinal triangle, but it's the same thing. But again, this is just completely due to weakness. It's nothing embryologic. It's no congenital deficiency or anything. And again, just think of like an older man trying to lift something heavy. So this is, so for context, this would probably be, on the left side. So here's like your ASIS, here's your pubic tubercle right here. So ASIS. And then this would be the deep inguinal ring. And I guess they took off part of the superficial just so you could see it. Oh yeah, it's back here. See that superficial. But anyway, it's going to herniate medial to the inferior epigastric vessel. So that would be over here, right? Because again, this is midline where the tubercle is. And it's going to go through this weak area, which is made up of this triangle known as Hasselbalch's triangle. And the borders of it are your inferior epigastrics are your lateral border. The rectus abdominis muscle, so like literally your ab muscles, are the medial border, and then the inferior border at the bottom is the inguinal ligament. So this is like the ligament that the canal kind of sits on. Here's another picture of Hasselbalch's triangle. So the herniation would be right through here, and then it would go kind of through this superficial ring. It would like come through that. Here's like a picture of it. So it goes through Hasselbalch's triangle, which is up here, and then it would go through only the superficial ring. So it's not going through the deep ring. It's not following the pathway of descent. It's just not, it's very different from indirects. Again, here's your inguinal or Hasselbalch's triangle with the 3 borders. And like usually this one's a little bit higher up, again, because you're not following all the way down through like where the spermatic cord is. You're really not going that far down. This is caused by an acquired weakness of the transversalis fascia, because remember, transversalis fascia is the first layer. It's covering pretty much all of like where the herniations would be. It's covering that. This does not follow the pathway of testicular descent, and it's not covered by all 3 layers of fascia. So it's not covered, just like indirect inguinal is covered by all 3 because it's literally within this canal. Indirect is not covered by all 3. It's really only covered by the most superficial layer because it kind of herniates through here, right? So inferior epigastrics, medial to it, comes in, and it just like picks up part of that superficial ring, and that's covered by external fascia. So how people remember the herniation is they say MDs don't lie. This is another one of those mnemonics I really like. So MDs, meaning if the herniation is medial to those inferior epigastric vessels, it's a direct inguinal hernia. If it's lateral, so MDs don't lie. Lie is if it's lateral to the inferior epigastric vessels, it would be going this way. It would be lateral. It would be an indirect because then it would go through the deep and superficial rings. Another picture. So again, this would be like on the right side in both instances, ASIS to the pubic tubercle. So indirect, remember, goes through both. It follows the pathway of testicular descent. Direct only really it goes through that weakness in where the inguinal triangle is, and then it only picks up the superficial ring. Okay, and then lastly, we have the femoral hernia. So a femoral hernia is going to be this really only happens in females. So people remember female, femoral. That's like kind of how they remember it. But what I really want to emphasize is this is a lot lower down than the other 2. So for example, like the inguinal ligament is above where the herniation occurs, whereas the last 2, the inguinal ligament was below the last 2. Okay, so for this one, it's going to protrude below the inguinal ligament through what's known as the femoral canal or the femoral ring, which is down here. and it's going to be below and lateral to the pubic tubercle. And this one, compared to the other two types of hernias, is more likely to present with strangulation, meaning you have a higher chance of losing the bowel compared to the other two. So super dangerous. And then there's this artery. It's called the aberrant obturator aberrant obturator artery. When you're trying to fix this hernia, you can actually like nick this artery, and it's sometimes they ask this as like an anatomy thing, like which artery is really, because they want people to pick the femoral artery, right? They're like, oh, femoral hernia, femoral artery, and it's not. It's the aberrant obturator artery. This is the one that's most at risk of getting like nicked for if you're trying to do like fix this herniation. Here's like another picture of it. There's something known as the femoral triangle, so you should know the border of that. The inguinal ligament is going to be the topmost border of this. The lateral border is going to be the sartorius muscle, which is just one of those flexor muscles, and then the adductor longus. So when you go to the gym and work your adductors, that's going to be your the most medial border of your femoral triangle. And the femoral triangle contains pretty much the femoral nerve, it contains the femoral artery, femoral vein, and then the lymphatics. But the lymphatics, this is the only thing that's within the femoral ring. This little tiny ring is what the bowel goes through in a femoral hernia. So that's why they're saying there's a very high risk of strangulation of the bowel. Sometimes they'll ask you most lateral to medial, like what's located lateral to medial. So navel. So this is going to be the nerve, artery, vein, empty, lymphatics. And then all of this is included within this femoral triangle. So again, it's just like an anatomy question. Sometimes they ask, what's the order from lateral to medial? Nerve, artery, so femoral nerve, artery, vein, and then lymphatics. Sometimes they'll say like, well, what's in the femoral sheath? And the femoral sheath it's pretty much like the femoral triangle, but it doesn't include the nerve. So I have seen questions where it's like, what is not included in the femoral sheath? And it's everything except the femoral nerve. But the femoral nerve is included in the femoral triangle. Okay, and then the femoral canal or the femoral ring, again, this is just lymphatics are in here, but this is where the herniation occurs. Okay, so same thing here. So you can see how low it is. It's a lot lower. Like the inguinal ligament is on the top, and then usually it's in females. So this is a female representation. You just kind of like have a bulge very low down. And like I said, and this is kind of like showing, and this would be like this is on like the left side. So this is the ASIS over here. This is the pubic tubercle here. But basically just don't forget with these that the whatchamacallit? What am I trying to say? So for the females, still the most common is going to be an indirect inguinal. With males, the most common indirect inguinal. But remember, if it's a femoral hernia, it's usually only going to be in females, and it's just because of like the anatomy of like a female pelvis versus the male pelvis. You'll go into that when you do OMM, especially when you do repro anatomy. But this is just kind of showing all of them. Here are your inferior epigastric vessels. If it's going lateral to it, this is going to be your indirect hernia. If it goes medial to it, this could be your direct hernia. And then above the inguinal ligament, below the inguinal ligament, this is going to be your femoral, and this is going to be where the femoral ring is. Okay, so I don't love this picture, but it at least shows all of them in once. And you can see here's the Hasselbalch's triangle, and then down here, it doesn't have it labeled, but like around here would be where like I actually think it's a little deeper, but it's okay. That's where the femoral triangle is. Okay, so I'm going to record. I'm going to stop recording here, and then I have to go, and then I'm going to come back and just record the questions so you guys can hear the thought process going through the questions. Okay? All right, so I will probably post just a second video that's going to be like 10 minutes of just me walking through the questions with you guys. Okay. All right, bye guys.